Good afternoon, all of you. I am Tilak Veeratne. My co-chair is Dr. Tushari Vanagaratne. Welcome to the first symposium after lunch, Biologics in Current Clinical Practice. This symposium will feature 3 speakers. First, there will be an overview on biologics by Professor Suranjit Senaviratne from UK, and he will continue to talk on biologics in respiratory medicine. And next, by biologics in rheumatology will be delivered by Dr. Kamal Stober, and Professor Arjuna Silva will talk on biologics in inflammatory bowel disease. Let me first introduce the first speaker, Professor Suranjit Senaviratne. Professor Senaviratne is currently at the Institute of Immunity and Transplantation, Royal Free Hospital and University College London, UK, and is also currently attached to the Department of Surgery, Faculty of Medicine, University of Colombo. He had his MBBS degree from University of Colombo with the first class honors and completed his MD in internal medicine and trained in clinical immunology and allergy at the John Radcliffe Hospital in Oxford. He completed a PhD in molecular medicine at the Weatherall Institute of Molecular Medicine, University of Oxford, as a Commonwealth Scholar. So far, he has authored 248 journal publications. Professor Senaviratne is an international expert on immunodeficiency, autoimmune allergic mast cell disorders, and immunogenetics, and is the director of the Center for Mast Cell Disorders and the president of the UK Sri Lanka Immunology Foundation. Over to you, Suranjit.
Thanks a lot, Tilak. Thank you very much for the invitation from the Internal Medicine organization. And can I share my slides? That is okay. Is that okay? Hello? Hello?
Yes, okay. We are here. We can see you.
All right, okay.
Right.
Okay, thank you. What's this? Slides are going down. Okay, thank you very much, Tilak and President and organizers for asking me to give this talk. Okay, so firstly, what I'll do is I'll talk about an overview of biologics, a quick overview of biologics, because that has come into internal medicine and sort of specialty medicine in a big way in different areas of medicine. And what we know is that medicine today, we have a population-based, one-size-fits-all model of care. And what we're trying to get to is a more personalized medicine, predictive, preventive, patient-centric model. We are using genomics plus other important, having a foundation of clinical sort of basic clinical medicine and clinical findings, and then using genomics to be able to target these different immune pathways and genetic pathways in different areas of medicine. So basically what we're trying to do is we're trying to get medications that are not toxic and beneficial, because rather than giving every patient the same sort of medication, which sometimes can be toxic and not very beneficial, we just want to target the specific group of patients so that we get optimal benefit from that particular group of drugs. So what I'll do in this next 10 minutes or 15 minutes is talk to you about the basics, monoclonal antibodies, about biologics and conventional drugs and biosimilars to round it off. Now we know the immune system, viruses, bacteria, and fungi can attack our body. You have the immune system, the defense system, which consists of antibodies, white cells, and complement. And these have to work in concert and at appropriate levels to be able to keep the sort of harmful agents outside our body and not causing damage. Sometimes what happens is these components can be defective, and then you have immune deficiency, and we have to boost the person's immune system. At times, you find that the immune system that's antibodies and white cells, can attack our own body cells, and this is called autoimmunity. And there are different autoimmune states, which will be discussed in the next few lectures. Sometimes you find that the immune system attacks innocuous substance in the environment, and that is allergy. So you have a normal state of the immune system, you have underactive the immune system, and then you have overactivity in a dysregulated fashion, in an abnormal fashion. And in those instances, we have to give sort of immunosuppressive agents or other agents, including biologics, to bring it back to baseline. So that is basically what we would do when a person with immune-related issues comes to see us, across from an immunology perspective or in organ-based specialists or at internal medicine level. So we know that there are different cells that are present in the body. From the bone marrow, it originates red cells, white cells, neutrophils, eosinophils, lymphocytes, T cells, B cells, etc. The B cells go direct into the bloodstream. The T cells go into the thymus, get educated there, and the non-harmful T cells come out of the thymus. Different types of T cells. You have CD4 cells, CD8 cells, B cells, which have CD19 on the surface, and NK cells, which have CD56. When we look at the T cells, we have different types: Th1, Th2, Th17, and Tregs. Now, depending on the condition, different cells have a greater role to play. Say Th2 cells would have a greater role to play in asthma and allergic disorders. Th1 cells would have a greater role to, and Th17 cells would have a greater role to play in autoimmune diseases, which will also be discussed in the symposium. And the important thing with regards to the immune, so you find that the B cells produce immunoglobulins and through plasma cells, and the immunoglobulins have these different components, which all of you would have learned in medical school: the variable component and the constant component. Now, it's important that the T cells, B cells, and the antigen-presenting cells work in concert together with the cytokines produced by the T cells. Those cytokines are just chemicals that the cells use to communicate with each other to be able to carry out the immune function. Once the immune system gets activated, you have to bring it down into baseline again, because otherwise you would find that the physiological functions are not met, and that is what happened in COVID, where you found more cytokines produced and a hypercytokine state coming. So this is a schematic to show the interaction between a T cell and the antigen-presenting cell, APC. You find that the T cell receptor is there, so you have an accelerator of the process, and that would get the immune system activated. But once the immune system gets activated, you do need to have two breaks. One is the CTLA4 break with CD18, and the other one is PD1, PDL1, and this is the basis of immunotherapy, the discovery of which won the Nobel Prize last year, or 2 years ago. So the important thing is, just because you have the immune system gets activated, you have to have a break, the CTLA4 break or the PD1, PDL1 break, or other breaks to bring it back to baseline. And in certain autoimmune diseases, this is important. In certain cancers, this is important. So next, going on to monoclonal antibody. That was a quick outline of the basics of the immune system and the different breaks and the accelerators of the immune system. Quite some time ago, it was Milstein and Kohler got the Nobel Prize for finding the technique for producing monoclonal antibodies. That is of one type, not polyclonal, but one type, monoclonal. And based on the different monoclonal antibodies and how it is produced, you can name it. And this is the sort of schematic that they use for naming the different monoclonal biologics that we have. It's MOMAB if it is mouse, it's ZMAB if it's chimeric, if it's humanized, it's ZUMAB, and it's UMAB if it's human. So you're looking at the name, we can sort of get an idea from what source this has this monoclonal antibody been derived. And so if you look at biologics, you have the novel biologics, including the antibodies, monoclonal antibodies, and proteins, growth hormones, interleukin, etc., and including vaccines and some peptides. And then you have the follow-on biologics, which are biosimilars and the biobetters. And biosimilars and monoclonal antibodies, I think biologics, I'd be just having a slide going on. So how do you compare biologics with conventional drugs? It's like a sort of the analogy that is being given is, if aspirin is like a bicycle, it is like a sort of a large biologic, it's something like a business jet, because the complexity is important when it comes to biologics, and that is very important in the manufacturing process, together with sort of the regulatory components in ensuring that the biosimilars, etc., are similar to the biologics that are being used. So what are the sort of comparison between traditional biologics? Traditional, you have multiple effects, short-acting, oral administration, quite a few of those are intravenous, and then the interactions. But biologic specific, long-acting, so you're trying to be more specific and take out different components of the immune system, or try to stimulate different components of the immune system to have its more specific effects, rather than going blunderbuss, like sort of trying to affect all parts of the immune system in one go. You want to be a bit more specific. Biologics have been quite prominent in recent years. Many FDA approvals have been biologics in recent years. This slide shows that schematic over the sort of years, but the problem is cost. Can we afford it? And this was a sort of editorial some time ago, but that is an important issue, because as more biologics come into play, can we afford these different drugs? And where does the world, who should we get to target these drugs? Because we should target them appropriately so that healthcare resources are used appropriately. So finally, the last few slides is about biosimilars, because I spoke to you about biologics, like what is it, including monoclonal antibodies. I told you about the conventional drugs, and talking about biosimilars. So if you look at the schematic, you have the traditional medicines, you have generic medicines, which are easy to produce because it is not so complex as opposed to biologics. Then you have biologic material, medicines, large molecules, and then you have biosimilars, which there are some characteristics that are laid down for it to be a biosimilar, similar to structure, pharmacodynamics, pharmacokinetics, etc., and safety and efficacy. So this is the sort of schematic that we use. There are the originals, the true innovator, and I've given some examples here. Then you have the bio-betters, the biosimilars. It becomes a bit more affordable over a range of clinical settings. And then you have the non-original biologics and the bio-betters to improve the efficacy and safety of administration. And those are the bio-betters. And certain companies who produce the original innovator also gets a bio-better to get better characteristics of the drug. So traditional generic, 2 to 3 years, biosimilars take some time. I mean, just because a biosimilar doesn't mean that it won't take some time. There is some development cost. And then you have the different biologics, which are the first generation and the second generation, which are the bio-betters to improve characteristics of that group of drugs. So trying to compare biologics and biosimilars, you find that these are the sort of characteristics. I won't go into great detail because of time constraint, but immediately you can see that there are differences between the biologics and the biosimilars that are present, that are given here. This has been for some time. EMA and Commission sort of published draft guidelines on marketing approval of biosimilar in the UK, and over the years, several biosimilars have come into use within the NHS and in different sort of settings. FDA approved the first biosimilar in 2015, and this was a sort of a biosimilar timeline. This is only up to 2018, but going on 2020, 2021, we have a number of biosimilars, including adalimumab, just come as a biosimilar. So I've just given a list of the drugs, the biosimilars that have been authorized over the different years here, and this is the next slide, which again shows a similar pattern of a number of biosimilars together with the biologics, their parent biologics that have been authorized. So valuation of global demand for biosimilars has been rising rapidly. 2020 level is very much higher than this, and it's a big market across the world for different pharmaceutical companies. So what I've done in this quick update was told you about the basics of the immune system, told you about the T cells, the B cells, and those acting together in concert, monoclonal antibodies, Cole and Milstein, and how they were produced, how they are named to depend on the source that it's produced, biologics conventional drugs. I compared those two, told you that conventional drugs take shorter and the properties of the conventional drugs, and then told you some aspects about biosimilars and how it compares with biologics, and what are the regulatory, there are some regulatory components with regards to biosimilars to be able to use those in and to come into clinical practice and to be able to use. Thank you.
Thank you, Professor Ranjit. And I think the next next presentation is also yours. That's you will be talking on biologics in respiratory medicine.
Yes, that's so. I thought I was talking third.
Right.
Wait, now. Okay. Am I not going third? Sorry. Yeah. Wait, let me close this. Sorry about that. I thought I was going third. Right, biologics in respiratory. Okay, so now we come to the sort of interesting clinical aspects which we are all interested in. The sort of boring aspect was out of the way, that is the sort of theoretical aspect. Now we come to the more interesting aspect. Can I share my slides? Can you see my slide?
Yes.
Excellent. I'll just post. Right, excellent. Right. So now we come to the more clinical part of the talks, I think, with starting with respiratory medicine. And so asthma would be the main focus of this talk because biologics have been big in asthma. So the bottomized summary of the talk would be, again, quickly run through the basics. I thought I was coming third. That's why I just quickly skimmed through the basics, which we have done: asthma, lung cancer, and interstitial lung disease. I know lung cancer is more for oncology, but just to give you a perspective about lung cancer, what medications have been used, and because those patients, same patients can, if they are receiving immunotherapy, can come to you with autoimmune disease, and you have to know certain aspects of those drugs that have been used so that you could use, know the possible adverse effects of those drugs. So again, I told you about the immune system, antibodies, white cells, complement, autoimmunity, allergy, and then allergy is where respiratory medicine, asthma, etc. comes in. So that is the component. And then Kamal and Arjuna will be talking about the autoimmune conditions after that. And the thing is to, to bring that back to baseline and, to take specific pathways rather than just using steroids ad hoc and just affecting every component of the immune system and just sort of blunderbuss approach of using big dose of steroids. We want to be a bit more selective in the correct, appropriate group of patients. This is not in every patient that walks into your outpatient room, in the correct group of patients. So if we look at, I told you the different types of cells. We are talking about the Th2 cell here, the one that produces IL-4, IL-13, and IL-4, IL-5, and IL-13. That is the important bit of cytokines when it comes to asthma and how we try to take it off. When it comes to cancer, we are talking about the CTLA-4 and the PD-1, PD-L1 pathway. Because in cancer, the lymphocytes go, but there is a shield between the cancer and the lymphocyte. We want to remove the shield. We want to remove the break, and that is immunotherapy. Because if you find colorectal cancer, breast cancer, etc., or colorectal cancer, lung cancer, the important aspect today, you find the lymphocytes going into the area, but they can't attack the tumor. That is what they have to do. They have to attack the tumor because there is a shield, and that shield is removed in immunotherapy, which I will talk in a bit later. So let's go to asthma and sort of focus on asthma and how it's sort of, where does biologics fit in basic management in the management of asthma. This is the GINA 2020 guidelines. All of you would be very, very familiar with this sort of guideline, step 1 to step 5. And we are concentrating on the step 5 category, the severe patients who are ending up in ITU, who are ending up in hospital, who are taking a lot of healthcare resources. But that's the group that we want to target with these different medications, not the standard asthmatic who gets a bit of wheeze once or twice a sort of month, etc. So the important group of patients who are on oral steroids or high dose inhaled steroids with a LABA. So that is the group in which the step 5, especially the step 5, is the one that has to be assessed and phenotyped properly and endotyped if possible, so that they are the appropriate biologics. It is targeted at that group. So if you look at this pathway, you have 2 different types of asthma. You have the allergic asthma, the non-allergic type, and you can see here, this is quite a complex sort of schematic. But basically, if I want to point out a few things, you have the eosinophil. Eosinophil is a very, very important cell, excellent for parasitic infection, has a lot of toxic chemicals. It doesn't have to go to the airway and release it because it can cause bronchial hyperreactivity, etc. So this, and then what is one that stimulates the eosinophil? It's a chemical called IL-5 produced by the Th2 cell. Then you have IL-4 and IL-13 are the 2 important cytokines, which are important for producing IgE, which goes and binds to the mast cells. Again, so those are the sort of the important cells when it comes to the allergic response. You have the non-allergic response, the neutrophilic response, which you phenotype and endotype them, and then that is to other cells in the immune system. So if I focus some aspects here, it's IL-5, IL-4, IL-13, and some other chemical at the top of the slide, just below airway epithelium, that is TSLP, which is the one that is produced, another chemical that is produced to initiate this whole process into the whole process. So if we look at this, you can see that you have a normal airway, you have eosinophilic asthma, you have non-allergic eosinophilic inflammation, you have non-eosinophilic asthma. So a whole range of things. Basically, what a respiratory physician or immunologist, allergist who sees this patient would try to do in this group of patients using different biomarkers, etc., to try and put them into different categories, skin test, the eosinophil count, etc. This is exactly what we do. And so basically, if you put a sort of snapshot of management of asthma, this is one slide that you just sort of take with the GINA guidelines, mass target treatment. Most patients receive ICS, LAMA, the whole range, the leukotriene receptor, anti-hormones, etc. So that is how we treat asthma, basically, a big rump of patient, nothing major, just, I mean, you target it, ensure that they take medicines, and that they will get adequate control of that. Then you stratify them, Th2, Th1, using biomarkers, and this is where you do personal asthma treatment to the group that is more severe. And then you have the different drugs, IgE drugs, anti-IL-5 drugs, together with the other agents, and these are the predictive biomarkers of response. So we use a few of these to be able to predict whether what patient should receive what drug and whether they are showing effective response. So if another schematic that shows the same process is, there are 5 classes of drugs that I want to talk to you. The IgE drugs, which are shown here, the IL-5 drugs, which are shown here, the anti-IL-5 drug. Then I won't talk too much about the anti-IL-13 because they were not the best drugs around. Then I'll talk about the IL-4, IL-13 drugs, the combined receptor blocking drug, and these are what I will talk in the next few slides. So what are the asthma drugs, biologics that we have? 5, I put 6 here, but 5 are the main things FDA approved. And omalizumab, mepolizumab, veslizumab, benralizumab, and dupilumab. I mean, these are drugs which are used. We use it on the different groups of patients based on the need, and there's different pathways. So again, remember, asthma, this is on a select group of patients who are going into GINA 5, etc., that will use this group of drugs. Quickly run through the thing. Omalizumab has been there for ages. I mean, it has been approved. It is approved up to 6 years of age. Used quite a lot of it. We use it in urticaria. I've used it a lot in urticaria for my practice a lot in urticaria, chronic spontaneous urticaria, which is not responding to standard treatment. Even in Sri Lanka, we have used that drug here, approved quite a long time. And there are certain, these were the first, so what does it do? It binds to the free IgE and it downregulates the receptor of the IgE receptor on the surface of mast cell. It's a wonderful, it binds to a site that doesn't cause cross-linking. And this has been there for ages. And we have a number of other second level anti-IgE medicines. IgE binds to mast cells, so that's an important medication when it comes to managing severe asthma rather than keeping them on high dose of steroids for ages and getting all the complications with regards to steroids, high dose of steroids. So we have different sort of tables that we use in asthma with weight and the IgE level, but in urticaria we don't use these. We treat them without using this table, but in asthma you do use this table, the weight and the total IgE level. And it can be used up to 6 years of age. So next we come on to the anti-IgE, then we come to the IL-5 drugs, the eosinophil, the one that causes the eosinophil to come to the site, and the one that causes the eosinophil to remain, to not die, but to remain long-term at the different site. Initial data showed that it was not benefit, but in recent years, we have found that mepolizumab, resilizumab, and benralizumab have been quite effective. This is one of the studies which are important, published in the New England Journal, which showed that basically, sorry, it is not this. I'm sorry about that. This is the omalizumab study, which I'm speaking, and this was the study that showed that omalizumab was effective across a range of, and this was an important New England Journal study. Coming to the IL-5 drug, you find that IL-5 drugs are inhibiting both the IL-5, which is found important by eosinophil survival and eosinophil coming to the site, and the IL-5 receptor, which is found on the surface of the eosinophil. So those are the two drugs, those are two areas that the drugs will try to target and get rid of. So what are the drugs? Mepolizumab. Mepolizumab, again, approved in 2015. You give it 100 milligrams subcutaneous 4 weekly. Very first-line drug in this group of patients, especially eosinophilic asthma, severe eosinophilic asthma patient. This was the study, the New England Journal study again, which first opened up this field, the Halder study, which showed that it was beneficial, but a small group of patients. This was followed up by the DREAM study, which is a bigger group of patients, published again by the Leicester group. And what they basically showed that there was a big difference between those receiving mepolizumab as opposed to those receiving placebo. So that was an important thing across 3 different doses. Next we come on to, and then it reduced asthma exacerbation, and it also reduced the glucocorticoid sparing effects. In 2014, 2 back-to-back papers came which showed that it reduced the amount of glucocorticoids, oral glucocorticoid, that are needed in this patient, the Bell paper and the Ottawa paper, which showed that mepolizumab was effective in treating severe eosinophilic asthma, both asthma exacerbation and to reduce the amount of steroids they're taking. So then we come on to resilizumab. Again, the difference, again, anti-IL-5 drug, but the difference was that this drug had to be given IV, and that's an important thing, while the other drug can be given subcutaneously at home. By this resilizumab, it has to be given IV, but it is important in certain groups of patients that we use, which I won't go into detail. The IL-5 receptor drug is benralizumab. Sirocco trial came out with this, showing the benefit of this study, and this is a great medication because we can use it 8 weekly, initially 4 weekly, but then we go on to 8 weekly, and we don't have to get the patient getting the drug too often. So that is the IL-5 receptor. The previous 2 drugs were IL-5 itself, and this again showed, the NIAS study showed that it has a glucocorticoid sparing effect in patients with severe asthma receiving this drug. So I've spoken to you about the IL-5, I've spoken to you about IgE, and the last two aspects I'll talk to you about is the IL-4, IL-13 receptor, which is an important drug to inhibit the effects of IL-4 and IL-13, and that is a drug called dupilumab, which you use a lot in atopic dermatitis, and also in asthma. It has been approved for asthma. So this dupilumab is a monoclonal antibody which inhibits both the IL-4 receptor and the IL-13 receptor, and therefore the signaling of that receptor through that receptor is reduced. And this was the first study, the Salivenzel study, which showed that it was very beneficial. It was beneficial in patients with increased eosinophil counts, and this was followed up by the Castro study, which showed that it was important and safe in patients in moderate to severe uncontrolled asthma. So we have another class of drug, again, FDA approved for severe asthma, not managed by the standard medication needing oral corticosteroids or high-dose inhaled corticosteroid. So those are the 5 classes of drugs that I would want you all to take home from this place. This is the RAB study, which again showed similar data, back-to-back studies in the New England Journal. So the 5 classes of drugs are omalizumab, mepolizumab, resilizumab, benralizumab, dupilumab. I told you about TSLP. It's higher up. It's produced by the epithelial cells of the airway, and that can be inhibited. And there's a drug that is in the development and would be used. That is tezolizumab, and that was acting on this higher component for TSLP that is produced by the epithelial cells. The studies that have been published with regards to that comes next. And this was again, a New England Journal study which showed that this was beneficial in a group of patients who have severe asthma. So what I've done was gone through the different pathways, gone through the different medication that can be used in these different pathways, and these are the sort of schematics that we use in deciding whether the person should have omalizumab, how do you evaluate it, whether they should have one of the IL-5 drugs, whether they should have whether they should have dupilumab. And like rheumatology, like IBD, in asthma, you have different pathways in making these decisions. So if we go quickly, next 3 minutes on lung cancer and interstitial lung disease, just a few slides just to put you all into perspective, because this was on respiratory disease rather than asthma that I was only talking about. So lung cancer, the standard method, surgery, chemotherapy, radiotherapy, you know, we have targeted therapy and immunotherapy come into focus, and this is where the world is going with regards to treating cancer at the present moment, using the other three methods as sort of a foundation. So depending on the genetic mutations, lots of genetics are being done very early in cancer care. Depending on the gene mutation or the fusion or the exon changes, you can go for targeted therapy or for immunotherapy based on that. The EGFR pathway is important. You study these pathways, you can intervene at different levels using different inhibitors. And this is just a busy slide, but just to show you the different drugs that have come in, including immunotherapy, into the management of lung cancer. And that is a big area of sort of research and clinical medicine, because lung cancer is a difficult cancer to treat with the sort of baseline methods, and you do need targeted therapy or immunotherapy. These are the sort of targeted therapy drugs that have been used based on the pathway that is affected, and cancer immunotherapy consists of the different immune checkpoint inhibitors that are being used, and you will see increase in C patients because some of them get autoimmune disease. So this is the immune checkpoint inhibitor, the PD-1, PD-L1 blockers. So finally, I want to end up with telling you that even in interstitial lung disease, you have certain medications that have been so interstitial lung disease, finally, both in sarcoidosis and other interstitial lung disease, you have a whole range of biologics that are being tested at the present moment. It integrates with the rheumatologists, etc., because of the common disease pathways. But I won't go into detail, but just to tell you that the number of in working on, including the anti-TNF drugs, which will go in importantly with the other two conditions. And this was a quick run through, basically, of the basics: asthma, 5 drugs, IgE, anti-IL-5, and the IL-4, IL-13 receptor, and TSLP, lung cancer, targeted therapy, immunotherapy, and interstitial lung disease, which are coming to focus with regards to TNF and the rituximab and the other drugs. Thank you.
Thank you, Suranjit. And for the want of time, and we will move on to the next presenter, and my co-chair will introduce the speaker.
We'll move with the next lecture. The topic is Biologics in Rheumatology. The lecture will be delivered by Dr. Carmel Stober. Dr. Stober is a consultant rheumatologist at Cambridge University Hospital, UK. She had academic clinical training in Cambridge and was a clinical lecturer in National Institute of Health Research. She has done many clinical researches and been presented at international meetings and several peer-reviewed articles. Over to you, Dr. Carmel Stober.
Hi. Oh, great. I can share my screen. Are you able to see my screen? Oh, hold on. Just a moment. Are you able to see my screen?
No.
No. Okay, hold on. Just a moment. Share screen. Here we are.
Yes, now we can see your screen.
You can see it now.
Yeah, thank you.
All right. So it's an absolute pleasure to be able to present this talk to you today. I'm sorry that I can't be there in person. I think that Professor Severanuri has provided a fantastic overview of the use of biologics and where we've got to with that. So I'd like to essentially talk to you about 2 key disease areas to illustrate the breadth of biologics that we're using in rheumatology. So rheumatoid arthritis, a little bit about clinical features, immunopathogenesis, the way in which we assess disease activity and outcome measures, biologic therapy, and I'm also going to briefly talk about targeted synthetic disease-modifying antirheumatic drugs. We don't have perhaps such sophisticated tools as there is in the world of asthma for treatment stratification, but I'll tell you a little bit about where we are. And then I'm going to compare and contrast that to psoriatic arthritis and axial disease, ankylosing spondylitis. So rheumatoid arthritis is essentially a chronic inflammatory joint disease, and it's characterized by the presence of autoantibodies. So in particular, rheumatoid factor, which targets the FC portion of IgG mostly, and also antibodies to citrullonated proteins, also called ACPAR. It's a disease affecting the synovial membrane, but is associated with damage to cartilage and bone. But we mustn't forget that it is a systemic disease. In Western populations, about 1% of the population is affected, and untreated disease is associated with significant morbidity and increased mortality. So here we have an overview of what the disease looks like. So we think of rheumatoid arthritis as a symmetrical small joint disease affecting the MCPs and PIPs. And this is early disease in panel A, whereas panel B is a patient with more advanced disease where we can see deformity, Z thumb, swan necking of the fingers, and synovial thickening here with quite significant deformity. This is a mutilans form of the condition. Radiographic changes are evident. So this is a normal MCP joint. We can see joint space narrowing, periarticular osteopenia, erosive disease here, and destruction of the carpus in panel F, ulnar styloid erosions, subluxation. Panel G is a rarer complication, pannus formation at the atlantoaxial joint. And these are some rheumatoid nodules. So if we think about disease, well, first of all, our patient that walks into clinic. Now, these are the ACR-EULAR classification criteria for rheumatoid arthritis. And of course, classification criteria are not diagnostic criteria, but they do help to focus our minds on whether or not we're considering a patient with rheumatoid arthritis. In order to enter most clinical trials, a patient would have to fulfill these criteria. So I said to you, symmetrical small joints of the hands and feet, and you get a higher score if that is the case. Presence of autoantibodies, so ACBAR and rheumatoid factor, and basically the magnitude of that antibody influences the score you get, symptom duration, and acute phase reactance. So moving on from that, once we're happy that our patient has got rheumatoid arthritis, how do we assess disease activity? So in the UK, we use the DAS-28, Disease Activity Score 28, which incorporates 28 joints, tender or swollen joints, acute phase reactance, and a patient global health or visual analog score. And here we can see classification of different disease states. So high disease activity is a DAS-28 of more than 5.1. And in order to access a biologic therapy, one has to have a failure of 2 oral synthetic DMARDs, usually including methotrexate, and have a DAS-28 score of more than 5.1. And here we summarize the biologics that we use in rheumatoid arthritis. So I'll briefly talk about this, and we'll see a schemata of where they fit into the pathway and a little bit about efficacy in trials. So tumor necrosis factor targets, I'll talk about the 5 different originator molecules in a couple of slides' time. So as we said, those with an X are chimeric antibodies, where so infliximab was the first anti-TNF, which is intravenous. The rest of them are used subcutaneously. Those that target IL-6 receptor, the originator, the one we've used most for the longest period of time is tocilizumab. There are newer molecules targeting IL-6 itself. We have an inhibitor of co-stimulation, so it's a CTLA-4 Ig, so abatacept, and then a B-cell blockade with rituximab. We've already heard about biosimilar DMARDs, and they have changed the environment to a certain extent, certainly with respect to cost. And I also wanted to briefly mention, although these are not biologics, in terms of efficacy, they are quite fairly similar, and they're the newest drugs we have available to us, the targeted synthetic DMARDs, the JAK inhibitors, baricitinib and tofacitinib. So in terms of the etiopathogenesis of rheumatoid arthritis, you can see the T cells sat in the middle here, and I would probably say that the etiopathogenesis probably combines both T helper 1 and T helper 17 mediated immunity. Although interestingly, T helper 17 blockers haven't been very efficacious in rheumatoid arthritis. So our inhibitors, so TNF inhibitors and IL-6 inhibitors, block the innate arm of the pathway, thus inhibiting the propagation or initiation of the disease, whereas abatacept and rituximab are more focused on the adaptive arm of the immune response. So T cell co-stimulation here in the form of abatacept, and with respect to rituximab, we're targeting B cells that express CD20 with a reduction in autoantibody and probably depletion of antigen-presenting cells. And despite the different biologics that we utilize, the efficacy of these biologics is quite similar, suggesting that perhaps there is a final common pathway. Over the time that we have utilized the different biologic therapies and JAK inhibitors, we've learned a bit about etiopathogenesis. So I've summarized this in a table here. So things such as osteoblast differentiation and activation with TNF and IL-6 blockade, for example, reduction in T cell activation with co-stimulation blockade, and not surprisingly, depletion of CD20 positive B cell lineages, although plasma cells in theory are spared. JAK inhibitors have a pleiotropic effect according to which JAK molecules they target. Now, in terms of clinical trial data and the way that the drugs are compared in clinical trials, the outcome measure is that of ACR 20, American College of Rheumatology Response Criteria 20, a 20% improvement in joint counts and 3 domains of this summary of characteristics here. And the reason I wanted to introduce this to you is to really compare the different molecules that we use. So essentially, this is a schemata of the TNF blockers. So infliximab, given that it has the X here, it's basically a chimeric antibody. The implication of that is the chances of it being immunogenic and you generating anti-drug antibodies is increased. These are fully humanized antibodies, adalimumab and golimumab. Certolizumab just incorporates Fab fragments, which means that the immunogenicity is reduced, and it's also pegylated. And the implication of that is that its ability to penetrate different tissues is increased. And etanercept biologically seems to be different. It's actually a fusion protein of one of the receptors for TNF. And I will just point out to you the implications of that in terms of efficacy in a couple of situations. This is quite a busy slide. I think the take-home message here that I wanted to point out was that despite the drug that we use for rheumatoid arthritis, our outcome measures are often quite similar. So on the right here, there are several different clinical trial data, and the pink bars are the ACR 20 responses, which are usually the primary outcome measures in clinical trials. So in A, these are patients newly instituted on biologic therapy, infliximab, adalimumab, and etanercept. And the take-home message here is they all compare quite similarly. So neither of those is more efficacious than the other in this study. In patients with active disease despite methotrexate, which may be that they've had disease for longer or they're non-responders to methotrexate, the responses are never quite as good. So we've got infliximab, adalimumab, and then etanercept here. And of course, in the real world, what tends to happen is, or what used to happen was, people were initially instituted on anti-TNF therapy because we'd used those for the longest. So we then are presented with our TNF inadequate responders. And what we find is once you've had experience of TNF usage, your subsequent response is never as good. So Dancer and Reflex, so this is Dancer, these are TNF naive patients, whereas Reflex down here are those that have had anti-TNF therapy. And overall the responses are not as good. And we see the same thing with Batacept, so AIM and ATTAIN. The reasons for that are multifactorial. This is a rather busy slide, but again, I wanted to introduce, so in a way, we've gone from non-targeted therapies to then targeted therapies, back to JAK inhibitors, small molecule drugs, which are, well, some of them certainly are non-selective. So tofacitinib and baricitinib are currently approved in the UK for the use in rheumatoid arthritis, and FDA approved as well. And they're non-selective. Baricitinib targets JAK1 and 2, and you can see here that means that multiple different pathways are inhibited, and then tofacitinib JAK1 and 3. With respect to clinical trial data, looking at the efficacy of JAK inhibitors versus biologics. So this trial here, oral standard, was tofacitinib 5 milligrams twice a day, the licensed dose versus adalimumab. And basically, it showed equivalence in terms of the ACR20 response. And then this study, RA-BEAM, which used baricitinib compared to adalimumab. And actually, what we can see in this study is there was superiority for baricitinib against adalimumab. Obviously, when we utilize drugs which are taking out parts of your immune response, there are going to be implications. So with respect to starting individuals on biologic therapy, one has to, in the first instance, obviously check a number of factors. So first of all, in our standard screening would be for tuberculosis. So we use quantiferon and just chest X-ray in the UK. Hepatitis B and C, all patients are screened for, and we would not utilize the drugs in the setting of active infection. Infection is a common side effect, respiratory and urogenital infections. There's a couple of scenarios where we would avoid particular biologics. We do see cytopenias, they're not usually that significant, and then sometimes deranged liver function tests and dyslipidemia. Injection site reactions are relatively common also. With respect to JAK inhibitors, bacterial infections in large clinical trials were similar for the JAK inhibitors and biologic DMARDs, but one unique signature for the JAK inhibitors is increased viral infections, namely varicella and herpes viruses, approximately twofold, and it seems to be generic across the different JAK inhibitors. Opportunistic infections and fungal infections were relatively similar, and similarly malignancy across the use of these. So solid tumors are not increased, but skin cancer globally is, hence we recommend surveillance. GI perforation is something that has been associated with tocilizumab, IL-6 blockade. Venous thromboembolic events, there has been some concern with JAK inhibitors, but large meta-analysis suggests that that is not the case. Now, we saw a pathway. Now, with respect to, this is our local pathway for the use of biologics in rheumatoid arthritis, and it takes into account NICE guidance and a number of technology appraisals for the different medications that we use. I'd already told you that a patient has to have a disease activity score of more than 5.1. They have to have had 2 oral synthetic DMARDs, including methotrexate, and we could switch to subcutaneous methotrexate. And then there are all of these different options available to us. The question is, of course, which one should we choose? NICE does recommend the lowest cost medication. And then some may be used as monotherapy, i.e. you don't have to use with methotrexate, which I've summarized here. Down here, this tells you what we need to identify as our outcome measure. So a EULAR moderate improvement in disease activity by 6 months. Stratification in rheumatoid arthritis. I think probably we're not very far along with this. So we think about patient factors as well as potentially biomarkers. So a patient may prefer intravenous therapy. And for example, if somebody's very obese, infliximab may be a good choice for that setting if someone has injection site reactions. In demyelination, if someone's ANA positive, we generally avoid anti-TNF therapy. Interstitial lung disease has already been mentioned today. And that can obviously happen relatively commonly in rheumatoid arthritis. So we would avoid TNF inhibitors in general and probably opt for abatacept or rituximab, and similarly in a setting of malignancy. If somebody has an IL-17 associated disease, so high acute phase markers, high ferritin, anemia of chronic disease, we may go for tocilizumab, for example. If somebody is anti-CCP positive, the chances are they'll do better than somebody that isn't with respect to the use of rituximab, abatacept, and tocilizumab. We don't look at the shared epitope, which is a type of MHC class 2 molecule, but that's another biomarker of disease phenotype to a certain extent. The STRAP study is an MRC-funded large study looking at the pathotype of the synovial membrane. So you have to have a biopsy for this, and patients are being stratified according to that, but that's not routine clinical practice. And I've left this here for you to peruse. That's a little bit about stratification and contraindications. So secondly, I briefly wanted to talk about psoriatic arthritis and how that differs to rheumatoid arthritis, despite being an articular disease. There are various phenotypic patterns that we see, and it's quite different usually to rheumatoid arthritis, but the unique features of it are enthesitis, so tendon attachment sites are affected, including things like Achilles tendons. It can affect the spine, spondyloarthritis or axial disease, and also dactylitis, which is probably a sort of enthesitis of the pulleys. There are various comorbid conditions, which includes inflammatory bowel disease and uveitis that we commonly see associated. And so one has to think about also the subset of disease, the non-articular MSK manifestations such as axial disease, and the comorbid conditions such as inflammatory bowel disease in stratification. Here is a general overview of the etiopathogenesis, and the main thing here that differentiates psoriatic disease from rheumatoid arthritis is the role of the T helper 17 IL-23 pathway. So IL-23 is the cytokine that essentially promotes the differentiation of a naive T cell down the T helper 17 pathway and the ongoing production of IL-17 and IL-22 in addition to TNF. Entheses is affected here, as well as the joint itself, but we think of it as a disease which is initiated at the entheses. Two things that I wanted to point out here. Okay, so approved drugs for psoriatic arthritis are listed in this table. I haven't included the JAK inhibitors, but essentially TNF blockers, IL-17 blockers, and then ustekinumab targets the IL-12/23 pathway in that it affects the P40 molecule. So etanercept, I mentioned earlier, is a fusion protein of the TNF receptor. Interestingly, in terms of skin, it has a relatively poor response compared to the joint response, whereas the other TNFs have a very good response in the skin. If we look at IL-17 blockade, an absolutely amazing response in the skin, and the response in the joint is reasonably good. Again, there are probably some, in clinical trials, it performs similarly to anti-TNF therapy. So this is one thought about stratification, which I wanted to summarize in this, this review article, actually, because recent clinical trials in ankylosing spondylitis, so I guess axial disease, have demonstrated inefficacy of IL-23 blockers. So that's either the IL-23 P19 or the 12/23 P40 blockers. So there's something different about that pathway for axial disease. Skin disease, we have superiority of the 17/23 blockers over TNF. And gut disease, and we're going to hear about inflammatory bowel disease. Interestingly, IL-17 blockade can make your inflammatory bowel disease worse. So these factors need to be taken into account in stratifying or thinking about your individual patient. This is quite a busy schemata, but essentially it's the GRAPPA guidance for managing psoriatic arthritis, and the EULAR guidance looks quite similar to this in that the disease is divided into domains. So when you consider your individual patient, you have to decide which domain is the predominant lesion, and that would help you to decide which treatment you may want to utilize. This is just about to be updated. So in summary, I've talked about a number of different molecules here. TNF blockers, they've been around for quite a long time. Their efficacy is quite similar in rheumatoid, psoriatic arthritis, and also axial disease or ankylosing spondylitis. IL-6 blockade works in rheumatoid arthritis, but not in psoriatic arthritis or ankylosing spondylitis. IL-17 inhibitors didn't meet their primary endpoints in rheumatoid arthritis, but work well in psoriatic arthritis and ankylosing spondylitis. And the 12/23 blockers have not worked in RA. They work in psoriatic arthritis, but not in axial disease. JAK inhibitors, efficacious in RA and psoriatic arthritis. There was some debate. I think this is ongoing work looking at ankylosing spondylitis. So final slide, we now have a number of biologic agents that are available to use across the diseases that we manage, but we don't really have very good biomarkers enabling stratification. Primary inefficacy, that means that the drug doesn't work first time, remains a problem, and that's seen in clinical trials as well as in routine practice. And secondary inefficacy, many reasons here. So the generation of anti-drug antibodies is just one example of why this happens. Omics may help us stratify in the future, and perhaps JAK inhibitors may overcome this issue. Now, I believe the questions are happening at the end of the session.
Okay, thank you very much.
Thank you very much.
Thank you very much, Dr. Stober. Now we'll be moving with the next lecture. Thank you.
Yes, the next lecture of the symposium is on biologics in inflammatory bowel disease, and the speaker is Professor Arjuna de Silva. Professor Arjuna is a consultant physician and professor in medicine in the Faculty of Medicine, University of Caledonia. Having obtained his MD in University of Colombo, he subsequently obtained MSc from University of Oxford, and he's a board certified as a trainer in gastroenterology, and he has had many involvements other than in medicine, right? He's a council member of the National Institute of Education, and he's the team physician of the Olympics, the last Olympics for Sri Lankan team. Over to you, Arjuna.
Thank you for that kind introduction, and first thank you for giving me this opportunity to speak. Also, it feels odd because I just feel I should have been in the UK talking, because so many speakers are from there. And Suranjit, it's always a pleasure to speak with him. So I've been given the task, I think the thing has been set very nicely, of biologics in IBD. So I'll just give you a case. This is a 45-year-old man who presented with a history of loose stools for 3 months with loss of weight. He had a past history of TB, and a diagnosis of Crohn's disease was made, and he was started on treatment with azathioprine. However, he did not improve, and he remained steroid dependent. So the question is, what are the issues and how you manage the patient? So we'll go through some definitions, always good as a mixed audience. So IBD is a chronic disease of unknown etiology. The word unknown probably is now is not that appropriate, affecting the gastrointestinal tract and comprising 2 distinct subtypes, that is Crohn's and ulcerative colitis. So what is a biologic? About 10 years ago, I think this was the question for the MD. A biologic is a drug produced by a biological organism. And what is a biosimilar? A biosimilar is an agent that is a biologic, and that is highly similar to another already approved biological medicine, or the reference medicine, or the innovator. So these definitions are important in this. The pathophysiology of IBD is very interesting, and this slide, I think, summarizes this well. So there is genetic susceptibility, which the evidence came from twin studies, and now finally GWAS, genome-wide sequencing. So the first was NOD2, and after now we have about 160 genes. Then the environment, smoking, diet, medications, and the key gut microbiota. Then intestinal permeability, again, goblet cells, Paneth cells, autophagy, all those. And the immune response, which is very important. The innate immune response, especially in Crohn's, cytokines, effectors, and regulatory cells. What about the prevalence of IBD? If you take the UK, it's about 200 per 100,000. Singapore is ulcerative colitis is 8.3 per 100,000, and in Sri Lanka it's about 5. These are our data, 5.3 per 100,000, and Crohn's is 1.2 per 100,000. However, this figure is now increasing, and we see what we see in most developing countries, that once UC starts, once the country gets developed, Crohn's overtakes UC. So we are in that process now, but we don't have the data to prove that as yet. But Crohn's incidence is increasing. We also note a female predominance for UC in Sri Lanka, which we can't explain, which was even there in the first case reports described here. So it's a genuine thing. What about the incidence? So if you take the incidence, this is the study done in our region. So we like to be ahead of Singapore in something, so at least our incidence of 1.5 of IBD is just over Singapore. So if you believe the hygiene hypothesis, you can say that we are more developed than Singapore. So that's about the range, but I'm sure that is much more now. What are the clinical features? Well, diarrhea is one of the main, blood and mucus in UC, but it can be watery in Crohn's, abdominal pain, fever, weight loss, RIF mass, and fistula formation in Crohn's, perineal disease. You also get a lot of extraintestinal manifestations, which may be why actually so many drugs that there is an overlap in the biologics. So in the eyes, you can get episcleritis, scleritis. You can get mouth ulcers, which are considered extraintestinal as well. Kidney, again, stones, more stones in Crohn's, and erythema nodosum, pyoderma gangrenosum, which is characteristic. And the arthritis, you can get, again, axial spondyloarthritis with inflammatory backache, which can sometimes predate the bowel symptoms as well. So as we said, immunology and IBD is linked, intertwined and linked well. So I'm sure you've been seeing diagrams like this the whole day. So here the initial trigger is the gut microbiota, at least microbiota polysaccharide, which is assumed to be. And when you have a leaky gut that enters the epithelium, passes the epithelium and enters and interacts with the antigen presenting cells and the macrophages, and that leads to secretion of inflammatory cytokines, including TNF, which then stimulates the immune cells. So it is assumed that Crohn's is more Th1 response, and UC is Th2. But we know that it's not that simple anymore, and there is Th17 use involved as well. So then this activation then destroys or in the mucosa, resulting in the active disease. again, another view of the same thing. It's also important that there is what you call trafficking of, like drug trafficking, trafficking of lymphocytes. So the circulation, especially when there is involvement or inflammation, these cells are attracted to that, and that's called trafficking. And that is increased again when there is stimulus. And TH helper cells again involved, and the Tregs or regulatory T cells are the inhibitory cells there. So again, that innate immune system is involved in IBD pathogenesis, the epithelial barrier, the goblet cells, Paneth cells, and the innate lymphoid cells, and the macrophages and the dendritic cells, which act as the antigen-presenting cells, and again the neutrophils and complement. So is the adaptive immune system, Th1 and Th17 in Crohn's disease, and Th2 in UC. And the T regulatory cells or Tregs are involved again in the regulation. This NF-kappa beta and JAK-STAT pathway are two separate pathways which help to activate NF-kappa beta. So NF-kappa beta is the intracellular or cytosolic receptor which binds and gives rise to the production of most of the inflammatory cytokines which are involved in IBD. So both these pathways are important because the biologics act via both pathways, at least mainly through the toll-like receptor. So toll-like receptors, it's postulated that bacterial polysaccharide binds to that and acts as the trigger. So bench to bedside is a common topic, but in IBD and again in rheumatoid as well. So this has been shown where we have used the pathophysiology, or people have used the pathophysiology to design drugs. And the fact that the drugs work then now is evidence that this hypothesis was correct. So again, there are so many drugs here. We will discuss them. There is usketinib, IL-1223, tocilizumab, glucocorticoids, which is just like blunderbuss therapy, filgotinib and tofacitinib, which are actually not biologics, but they are small molecules, but they are also involved. The anti-TNFs, and the MADCAM binding natalizumab and vedolizumab, which are gut specific. So here is a table with all the most of the biologics used in IBD. So you get the anti-TNFs, adalimumab, certolizumab, and golimumab, and infliximab, vedolizumab, natalizumab, and usketinib. So certolizumab is used only in Crohn's disease, while as golimumab is used in UC, and infliximab, as we know, is used in both UC and CD, as is adalimumab. Natalizumab and usketinib are also used now both in CD and UC. So it's interesting that etanercept did not work in IBD, even though it's an anti-TNF. So infliximab, adalimumab, certolizumab, which is pegylated, and golimumab, which is used in UC. Infliximab, we were involved in the first trial of infliximab. I can remember complaining to Suranjit that I had to do so much paperwork. Infliximab, the dose is 5 milligrams per kg, 0, 2, and 6, and then it's given 8 weekly. So that is the staple thing which we are using. However, since it's a chimeric molecule, as is discussed before, there are more antibodies produced and you can get resistance. Adalimumab 80 milligrams per day, and then day 2, and 2 weekly, then 40 milligrams every other week. Sometimes we start with a lower dose of about 40 milligrams. So they are used for both the induction and maintenance of IBD. In our region, one of the main problems is reactivation of TB. So our protocol, we do MAN2 chest X-ray routinely. And the other issue is malignancies like lymphomas, which can happen. Biologics, at least anti-TNFs, are safe in pregnancy. There is a large register called the PIANO register, which all the IBD patients who use in Europe, who use biologics are registered in. So it's classified as a class B drug in pregnancy. And certolizumab is pegulated, so it does not is not secreted into the breast milk. So in breastfeeding you can use it as well, but any case biologic, once it gets into the stomach, it will be destroyed. So what about the IL-12/23 usketinib, again used for both Crohn's and UC. Unit 1 and Unit 2 are the trials that gave evidence for that. And the dose is 260 milligrams if the weight is less than 55 kgs, and 390 if the weight is between 55 to 85, and 520 if the weight is above 85. And it's followed by a maintenance subcutaneous dose of 90 milligrams 8 weekly again. So infliximab is given IV, while adalimumab is given subcut. What about the anti-integrins? So vedolizumab, alpha 4 beta 7 blocker. It blocks the binding of MADCAM, or mucosal adenosine cell adhesion molecule 1, and prevents T cell adhesion and infiltration. So since the integrin alpha 4 beta 7 receptor is found more in the gut epithelium, this is gut specific. So the importance for us is, unfortunately, it's not available for us to use in this country. But it is ideal because it does not reactivate TB. So you can use it even in a patient who has had TB in the past. So the dose is 300 milligrams IV infusion at 0, 6, and 2, and then every 8 weeks, similar to infliximab. It can be used in TB as well. And natalizumab is alpha 4 beta 1 blocker, and the dose here is 300 milligrams IV infusion over 4 hours, 4 weekly, and it's discontinued at 12 weeks if there is no response. What about the JAK kinase inhibitors and other small molecules? So tofacitinib was the first of that, and filgotinib, there's a current trial which we are part of as well, called Diversity, which has been run with both UC and Crohn's disease. So this, as a side effect, herpes, yes, it is a problem even with filgotinib, but it is less with filgotinib. It is more specific JAK kinase inhibitor. So they are not really biologics. They are small molecules. And again, they're used for the treatment of both CD and UC. And there is also another small molecule called ozanimod, which is a sphingosine 1-phosphate receptor blocker. It's an anti-trafficking drug. It stops the movement of the inflammatory cells into the mucosa. A few things about clinical trials in IBD. Very interesting history here. So in 1955, the first clinical trial showing efficacy medical treatment of cortisone in IBD, again done in Oxford. First head-to-head trial in IBD, sulfasalazine and prednisolone versus azathioprine. Then in 2002, first clinical trial showing efficacy of anti-TNFs, infliximab. What we must say is that most of these drugs have been pinched from rheumatology and psoriasis. They have been developed for those, and then the gastroenterologists have pinched that. So again, first head-to-head trial IBD, including infliximab and azathioprine. In 2013, vedolizumab was shown, and the clinical trial in 2017, which I'll come to, is a head-to-head trial in IBD as well. So clinical trials in IBD, Accent 1 and Accent 2 were the initial trials for infliximab. SONIC is an important trial, where infliximab and azathioprine combination was better than either alone. And the fact that you can switch from a originator to a biosimilar was shown first in the NOR-switch trial. Again, in IBD, for main reasons, economic reasons, no company is happy to have head-to-head trials. But this varsity trial was one of the first head-to-head trials between different classes of biologics, vedolizumab versus adalimumab in UC, and that showed that in UC, with certain caveats, Vedo is better. So the future of clinical trials in IBD, there's so many trials going on. In the sake of time, I'll just move on to the next one. So these are the newer biologics, atolizumab, brasculizumab, gulizumab, and mirikizumab, which the first three are mainly more specific IL-23 blockers, but there are more drugs in the pipeline, millions actually. So there is another important thing to remember. There is a paradigm shift in IBD treatment. It used to be clinical symptoms, and now it's mucosal healing. And the CALM trial was the first to show that dose escalation in IBD with an anti-TNF agent that was used was adalimumab will lead to mucosal healing. That's very important. So coming back to our case to conclude, the patient was not responding to azathioprine, so he has to be put on a biologic. He has a past history of TB, so the ideal drug would be vedolizumab. But if you have TB, according to the guidelines, if you have a positive MAN2 test, then you treat for TB for 6 months and then use the biologic. So to summarize, IBD is a disease of unknown etiology. It has a definite immune basis, and it involves both immune and acquired immunity. And treatment with biologics and immunomodulators help support the immune basis of IBD. Biologics are safe and effective treatments in IBD, and mucosal healing is the holy grail which we follow. So I'll leave you with this from the Game of Thrones. The future is like the past. And this is the future of some IBD treatment, fecal microbiota transplant in a pill. Thank you.
Thank you. Thank you, Professor Arjuna, for your interesting presentation. As we are running behind schedule, I'm sorry that we will not have a time for questions. And I take this opportunity to thank all three resource persons, two joining from UK, Professor Ranjit Senaviratne and Dr. Kamal Stober. Thank you very much for your participation in this symposium, and we learned a lot from your presentation. And Professor Arjun De Silva, who participated in person, thank you very much, Arjun.
Now may I call upon Professor Tilak Veeraratne to hand over the certificate of appreciation to Professor Arjuna De Silva. Thank you, sir. With that, we conclude this symposium. I would like to thank you all for joining with us. Thank you very much.
Good afternoon. You all are welcome to the first guest lecture of SIMCON 2020 on management of stable cirrhotic patient by Professor Anuruddha Dasanayake. Professor Anuruddha Dasanayake is a specialist physician with an interest in liver disease. He is currently a professor in the Department of Pharmacology, Faculty of Medicine, University of Kelaniya. He graduated from the Faculty of Medicine, University of Colombo. He had his training in hepatology at the North Colombo Teaching Hospital, Ragama, and liver transplantation from the liver transplantation unit of Royal Free Hospital, London. He is a member of North Colombo liver transplant team. He is an executive committee member of the South Asian Association for the Study of the Liver. His main research interest lies in non-alcoholic fatty liver disease and liver transplantation. He has over 60 publications in national and international journals and has presented more than 100 abstracts in national and international fora. Over to you, sir.
Thank you, Chairman, sir. Good afternoon, ladies and gentlemen. First, I would like to thank Professor Tilak Jayalat and the Council for inviting me to give this talk on how to manage a patient with stable cirrhosis. Why cirrhosis is important for the general physician? Firstly, because most of the patients with cirrhosis are still diagnosed and treated by the general physician. And cirrhosis is predicted to become one of the most common causes of death in the productive age group in the future, maybe even surpassing cardiovascular disease. And cirrhosis is mostly asymptomatic and also diagnosed by the hematologist, surgeons at surgery, hematologists when they present with thrombocytopenia, surgeons when they open up for any other illness, and by radiologists when they are referred to them for other illnesses basically. And also because there are major advances in the management of cirrhosis which could delay the decompensation and death. And to achieve this, this has to be diagnosed as early as possible. So I will start with the case scenario. This is my batchmate, dear friend. At that time he was 52, who was diagnosed as having cirrhosis at gallbladder surgery, laparoscopic cholecystectomy by a surgeon. And he was perfectly asymptomatic at that time. And he has had mild elevations of ALT, that's SGPT, which was attributed to attributed to fatty liver, but his mother had passed away many years ago at the age of 65 years with the diagnosis of cryptogenic cirrhosis. So obviously, even a medical student should be able to diagnose cirrhosis macroscopically. And that's why I think we should not be surprised that it was diagnosed by a surgeon. So being a close friend of mine, he obviously has had a lot of questions from me. Basically, he was very worried about it, and first question was, how long am I going to live? Then, will I need a liver transplant? How can it be a suitable candidate for transplant when it become indicated? Is there anything that will delay my progression? My mother had it and I have a daughter. Will she get it? And most importantly, his question was whether we can prevent cirrhosis in my child. So I will give you the answers to all these questions at the end of my talk. So obviously, cirrhosis is divided into compensated cirrhosis and decompensated cirrhosis. We all could easily diagnose decompensated cirrhosis when they are icteric, when they have ascites, when they have varices, bleeding, ankle edema, lethargy, weakness, then we all can diagnose this. But I am concentrating on stage 1 where there is none of these present, like no varices, no edema, no encephalopathy, because that's the most important stage for us to do some interventions and delay their decompensation later on. So what's the life expectancy in these patients? Very early cirrhosis, when they don't have varices, they are expected to live 10 or 20 years and even longer. But they can die of unexpected issues like hepatocellular carcinoma, viral hepatitis, drug-induced liver disease, and so on. We'll discuss these in detail. When they develop ascites, that's child's B, life expectancy drastically reduces to about 3 years. And then that's the time for us to think of a liver transplant. When they develop, when they have diuretic resistant ascites and when they need regular paracentesis, life expectancy drastically reduces to about 6 months. So, most important question that should be answered is, can we delay progression in these patients with child's A cirrhosis? So this should be our objective. Why? Because transplantation is not an option for all patients with cirrhosis. Why? Cost 10 million even for the government. So as a third world country, we just cannot afford transplanting all patients with cirrhosis. Then organ shortage. We just don't have organs to be transplanted. Even if we find organ, that's a fatty liver. So fatty livers cannot be transplanted. And then we need expertise. There aren't many surgeons around, maybe 1 or 2 for the entire country who can do a transplant. And even live donor transplantation is not suitable because there are other comorbidities. You can't take a liver from a diabetic. You can't take a liver from an alcoholic. So these issues are being so common, transplantation is not an option for all. And even in developed countries, transplantation is offered only about 25% of the patients who actually are decompensated at the end. So what's a new concept in the management of cirrhosis? So this professor, legendary British hepatologist at the Royal Free, the unit of Sheila Sherlock, Dame Sheila Sherlock, just before he passed away from a cancer, he just wrote in the Lancet, so the challenge in the 21st century is to prevent the need for transplantation in as many patients with cirrhosis as possible and not liver transplantation. So how can a patient with stable child's A cirrhosis die unexpectedly? Number 1 is liver cancer. Number 2 is acute on chronic liver failure, that is some kind of a hepatitis or hepatic event on top of a partially diseased liver. So objective is to prevent these, which can be prevented fairly easily, I would say. And also at the same time, they could die from an unexpected illness like myocardial infarction, which is still the #1 cause of death in a patient with non-alcoholic steatohepatitis. So being the #1 liver disease in our country, we should be aware of other illnesses, because we should be, if we are as a physician managing cirrhosis patients, we should be dealing with comorbidities, because even in a NASH patient, main cause of death is myocardial infarction. So another patient, I'm going to discuss 3 patients today. A 55-year-old asymptomatic man developed fever with rising AST/ALT, and he was positive for both dengue and hepatitis A IgM. And although the AST/ALT started recovering at day 5, bilirubin and INR started going up, and he succumbed on the day 19 with liver failure. Ultrasound established cirrhosis. So he was asymptomatic up to the presentation, but he got an acute insult. Clinical picture was more in favor of dengue, and he passed away. So acute on chronic liver failure that we have to look for in these patients who are not responding to usual treatment. So what is acute on chronic liver failure? That is acute decompensation in a patient with chronic liver disease. So all these patients, most of these patients are asymptomatic till they are decompensated. So how can this happen? Any other insult like viral hepatitis, dengue, drugs, infection, alcohol binge, variceal bleed, anything can precipitate liver failure, and this is extremely difficult condition to treat, and they usually succumb to the illness unless they are transplanted early, which is not an option in our country. So how to delay decompensation, how to prevent liver transplantation in these people? There are many measures, specific measures and general measures. We'll discuss one by one. So main intervention is treat the underlying cause. So if you know the cause like Hep B, Hep C, alcohol, autoimmune, Wilson's, you treat the underlying cause. That's very important. Then surveillance of for hepatocellular carcinoma. If you are looking after a patient with chronic liver disease or cirrhosis, if you are not doing the ultrasound scan every 6 months, you are not doing justice to the patient. So you should be doing surveillance ultrasound scan every 6 months, plus an alpha-fetoprotein to see whether they are developing a hepatocellular carcinoma. Then vaccinations, especially against hepatitis A and B, and most of our patients, most of adults in Sri Lanka are non-immune for hepatitis A even. So I think you should be checking for hepatitis A. Hepatitis B, anyway you test for a serotic, but hepatitis A, you should be checking, because now being a middle income country, our hygiene levels have improved, and majority of cirrhosis patients are non-immune. We have done a study on that, and you should be vaccinated against hepatitis A and B. Then should be variceal surveillance, because very difficult to manage when they bleed, which you should be taking preventive measures before bleeding like beta blockers and prophylactic banding. So as I discussed a slide before, can we treat we should be concentrating more on NAFLD, fatty liver and alcohol, because more than 90% of patient burden with cirrhosis is either fatty liver, non-alcoholic fatty liver, or alcoholic liver disease. So obviously we can treat hepatitis B, there are drugs. We can treat hepatitis C, there are drugs. Both diseases can be cured. Autoimmune hepatitis responds very well to steroids. Wilson's disease responds very well to treatment. Hemochromatosis can do venesection, that is rare in our country. Alcoholic liver disease respond to abstinence. So if someone is drinking, you should make sure that they abstain, because it's as good as treating hepatitis B, because that's the treatment. You are removing the etiology. So you should make every effort for them to stop alcohol, like referrals and various drugs, medications available for make sure that abstinence is maintained. See, NAFLD, million-dollar question, what can be done? Yes, even in NAFLD, all the lifestyle modifications that are known to be beneficial in NAFLD, like say weight reduction, exercise, avoiding junk food, so we don't have RCTs to tell you that, but obviously they should have some effect, and even vitamin E and obeticholic acid, there are RCTs ongoing on these. Results are awaited, but there is no reason as to why they should not be working in child cirrhosis. So can consider them if there is very, very early cirrhosis due to fatty liver disease. Immunizations, Hep A, yes, as I told you, nearly half of our patients are non-immune, hepatitis A, obviously hepatitis B, obviously others like say influenza, and then COVID, everything, whatnot. So vaccinate them, because if they get one of those serious illnesses that can be prevented by vaccination, there's a chance of them going into acute on chronic liver failure. So avoiding other risk factors, very important. So obvious liver toxins, we all know them, how toxic they are to the liver. NSAIDs, even a tablet of diclofenac sodium can kill you. Methotrexate, coamoxiclav, anti-TB drugs, chlorpromazine or Lagactil, and even herbs. So unknown herbs. So I generally tend them to avoid all unknown herbs. So unless some takes like say asking them to take Candhanol, so why not Mukuno and Gotokola and all, but not to go for unknown herbs. It's a major habit in Sri Lanka for them to go for these herbs when they develop liver disease. So what general measures for across the board for all patients? Losing weight is beneficial to the liver. Then avoiding hepatotoxins, I have told you, avoiding alcohol, avoiding smoking, and beneficial taking coffee, at least 2 cups of coffee a day. And the new kid in the block, nutrition, and it should get a nutrition involved, and exercise. I will discuss them in great detail in the future slides. Alcohol abstinence is mandatory for all cirrhotics, not only for alcoholic cirrhotics, because it reduces the incidence of hepatocellular carcinoma, even in other forms of cirrhosis. Cigarette smoking increases fibrosis. Again, it's mandatory for them to stop smoking. And coffee, good evidence to suggest that coffee is beneficial in all forms of liver disease, especially fatty liver, and even liver disease with advanced fibrosis, and even in cirrhosis. This, I told you, this is something new, nutrition and sarcopenia in cirrhosis. Cirrhosis is a hypercatabolic state with loss of muscle mass, and loss of muscle mass is directly related to the mortality even before and even after transplantation. You should maintain good nutrition is mandatory, and exercise regime from the beginning is mandatory, and even in guidelines say that to do CT scan to check for the muscle mass and start various programs to maintain muscle mass. In foreign countries they do that, but still we have not done it the proper way. But I think in the future they will have a CT scan at the beginning. Anyway, they will be doing CT scans to check for hepatomas and other portal vein thrombosis and so on. So at the same time we can include this kind of investigation into the same protocol to check the muscle mass. So sarcopenia, when you have sarcopenia, it predicts mortality, pre-transplant, post-transplant mortality. So maintaining muscle mass is a priority from the beginning. Obviously, we really do not know exactly what to do, but correct nutrition and exercise is thought to at least maintain good muscle mass. So a lot of papers are coming on maintaining the muscle mass, and I'm sure it will be included in the guidelines in the future. So exercise, again, important, and it will help to maintain the healthy feeling and also maintain the muscle mass. So guidelines on nutrition, what the European guidelines say, nutritional assessment by a nutritionist, including assessment of the muscle strength and muscle mass at the beginning. So nutritionist, liver nutritionist should be involved from the beginning to check the check the nutrition, diagnose malnutrition, diagnose obesity, and then take the corrective measures. And nothing is excluded in cirrhosis other than alcohol. You can eat and drink anything except alcohol, and should be on a regular normal energy diet, 35 kilocalories per kg, and normal protein. So in the past, there was this issue on protein restriction that is no longer valid, and you should be taking normal or even higher than normal protein intake in this patient to maintain the muscle mass, which is related to the life expectancy. So if obese, weight loss can be recommended with a kilocalorie deficit while maintaining the protein intake. Pharmacological treatments with survival benefit, again a new topic. Statins, metformin, carvedilol, rifaximin, the antibiotics, and query anticoagulation. So although there are no randomized controlled trials to prove that epidemiological evidence suggests that these drugs are important. So most of our patients with cirrhosis, with underlying NASH, have an indications to start these. So if they are already on statins or metformin, please do not stop them just because they started having cirrhosis. So if you continue them, probably they are going to be beneficial in the long term. So statins are thought to be something like, say, carvedilol or losartan or captopril to liver, a drug with survival benefit in liver disease. Observational studies, animal studies, theory all points towards benefit, and at least 4 randomized controlled trials are on with statins in both compensated and decompensated cirrhosis. Right? These are the mechanisms that are thought to be beneficial. Angiogenesis reduces cancer, then portal hypertension, and so on. So there are a lot of probably same mechanism as in cardiovascular disease, but it's going to be beneficial. The issue is that we have not been giving statins to patients with liver disease because of this issue with raised transaminases. That argument no longer valid. So I think we should be thinking of finding a indication to start a statin in this patient, because most of our patients will have some indications to start a statin, like diabetes or hyperlipidemia or young MI in the family or something like that. So find an indication and start a statin, because still the statins are not recommended in any of the guidelines, but there are enough evidence to encourage the use of statins in a patient with cirrhosis. So the Journal of Hepatology last year published this statin, all drugs as new therapy for liver disease. So this concept to be better than any of the new drugs that are being evaluated for chronic liver disease. So to change the topic to hepatocellular carcinoma, I will give an example. My third and final patient, a 55-year-old man followed by endocrinologist for type 2 diabetes for many years. So people with diabetes are followed up for many years, 10-15 years, without checking their livers. So this is the final result. When he started complaining weight loss for 6 months, the endocrinologist attributed it to metformin. The patient had 2 family members who are consultants and taken to another physician, and he diagnosed liver cancer. It was inoperable, and he passed away 6 months later. So very unpleasant situation he was in. So what's the reason? He has had asymptomatic cirrhosis for many years till he developed and presented with a hepatocellular carcinoma. We should not be facing this situation now with all these new guidelines on detecting, screening diabetics for fatty liver. He should have, NASH should have got detected many years ago, and cirrhosis should have got detected many years ago, and should have undergone the surveillance for hepatocellular carcinoma, which should have detected when it was less than 5 centimeters, and when it was amenable for some kind of a intervention. So why hepatocellular carcinoma should be identified early? Because it's the most important cause of death in cirrhosis. And even patients with fibrosis and early cirrhosis are at risk of developing a hepatocellular carcinoma. And all patients with cirrhosis should be having a surveillance ultrasound scan by an experienced sonographer. And what they say is, it takes 30 minutes to do that by an experienced liver sonographer. So I don't think we can achieve that in our country, but at least someone reliable should see the liver every 6 months. And some Indian hepatologists say that we have higher risk of cancer in this South Asian region. We should be undergoing, if someone has cirrhosis, they should be undergoing CT scan every 2 to 3 years, because ultrasound scan can miss a hepatocellular carcinoma. What a general physician should know about liver cancer? A lot, because it occurs only in the background of a cirrhosis. Usually you don't see hepatocellular carcinoma otherwise. And who is responsible? Medical gastroenterologist, not the oncologist, not the surgeon, because they don't know how to manage cirrhosis. So physicians should be looking after cirrhosis and just an extension of cirrhosis, just like varices. And it's the medical person who is responsible for the treatment option as well. He is the one who is referring to surgeon or radiologist for intervention. When it is less than 5 centimeters, curable when it is less than 5 centimeters. And treatment options and the prognosis depends on the stage of liver disease. If someone has stage or child C cirrhosis, it's not easy to treat it. And diagnosis is radiological, and there's no place for systemic chemotherapy. So no point of sending them to Maharagama. So this is how diagnose arterial enhancement and venous washout. So this is how you diagnose hepatocellular carcinoma. Who is looking after? Medical gastroenterologist. So liver transplantation, you should know a bit about liver transplantation. Indications: when someone bleeds, 1 episode of encephalopathy, diuretic resistant ascites, liver cancer, should be referred for liver transplantation if the facilities are available. When to refer to the gastrophysician? Depending on the accessibility. If you are uncertain regarding the etiology, because you don't miss an treatable etiology like autoimmune hepatitis. For variceal surveillance, medical gastro is better than a general surgeon for endoscopy, because he will tell you exactly what to do. The beta blocker, when to do the re-endoscopy and so on, when to ban prophylactically and so on. And if you detect a space occupying lesion, portal vein thrombosis, when they decompensate, to take transplant decisions. So my friend, what should I tell him? Yeah, do the surveillance, vaccinations, if metformin, if diabetic, lifestyle modifications like BMI, coffee, stopping smoking, alcohol, nutrition, zinc, beneficial exercise, manage cardiovascular risk, and no indications for any beta blockers, no diuretics, no PPI, no lactulose, because they don't have any indication to start these. Yeah. Answers to those questions from the first patient. How long I am going to live? 10, 15, 20 years. When will I need a transplant? How can I be a suitable candidate for transplant? So transplant 10, 15, 20 years. Make sure that you have good coronaries, good kidneys for a transplant. Surveillance for hepatocellular carcinoma. Is there any drug, any other measures to delay progression? Yes, a lot of measures. I told you in detail. Will my child get it? Very likely, because it's all genes. Can we prevent cirrhosis in the child? Probably, because so much of research is going on in the field that within the next 2-3 years we'll get something that will reverse the progression of fibrosis. Summarize ladies and gentlemen, Chairman Sir, decompensation of cirrhosis could be effectively delayed by interventions. Cirrhosis should be diagnosed as early as possible. Treatment of the etiology is the most important intervention. So is surveillance for hepatocellular carcinoma. Also immunizations. No recommended pharmacological intervention available for reversal of fibrosis yet, but statins appear to be most promising intervention. Correct nutrition and exercise regimes, taking care of other existing illnesses should lead to better life expectancy like heart and make the patient suitable liver transplant candidate. After 15 years, your coronaries are not good, you can't be transplanted. So make sure that coronaries and kidneys are in good health so that you can face the transplant, which take about 10 hours to complete. Thank you very much for patient hearing.
Thank you very much for the excellent presentation. I'm sure after this stimulating presentations, the audience may have a few questions. I think probably we could accommodate 1 or 2 questions from audience. Are there any questions from audience?
Apart from radiological screening for liver cancer, how often you have to repeat your liver function test if you are managing a stable patient?
Well, to test for the liver cancer, you do the ultrasound scan and alpha fetoproteins every 6 months. So if the patient depends on the stage of the cirrhosis. If child's A, it's not necessary for you to do the liver function test very often, but say child C, if they have ascites, they are on diuretics, then they need to be tested very frequently. That depends on the stage. Very early cirrhosis, just they behave like a normal human being, but say that's very healthy human. But say child C cirrhosis, especially they are awaiting a transplant, they should be monitored very, very careful. At the late stages, you should be doing INR, bilirubin and creatinine. That will tell you what's called the MELD score. MELD score will tell you how serious the condition is and how long you are going to live. So to detect the MELD score, you need the creatinine, INR and bilirubin. With those 3, we should be able to tell the patient exactly how long you are going to live and when you need the transplant. So it depends on the stage of the cirrhosis.
Okay, thank you very much. With the absence of any further question, I would like to invite my co-chair, Dr. Amara Vidarana, to issue the certificate as a token of our sincere appreciation. Okay, now let's move on to the next guest lecture. I am pleased to introduce our next guest lecturer, Dr. A. Muruganathan. He's a very special guest from India, and he's a well-known authority on hypertension. And he's an emeritus professor in medicine at Tamil Nadu, Dr. MGR Medical University. He's a chairman of AG Hospital in Tamil Nadu. He was a dean of the Indian College of Physicians, and he held the post of president of Hypertension Society of India, Association of Physicians of India, and Tamil Nadu IMA. He's the governor of Indian chapter of American College of Physicians. He was the editor of the Manual of Hypertension in 2015 and 2019. He received the B.C. Roy Awards from the President of India in 2005 and Best Performing Doctor Award from Tamil Nadu government on Doctors' Day in 2014. Today, he will speak on a dilemma in hypertension. Over to Dr. Muruganathan.
Thank you very much for that nice introduction. At the outset, I thank the President, Dr. Tilak Jayalath, and the conference chair, Suranga, for inviting me to give a talk in your Sri Lankan internal medicine meeting. The topic I have chosen is dilemmas in hypertension. Friends, all of you know hypertension is a big health problem as well as economic burden globally. There's a rapid advancement in science, knowledge, evaluation, diagnosis and management of hypertension. But unfortunately, we are still unable to control hypertension epidemic. Not able to manage various dilemmas of hypertension, like availability of sphygmomanometer. I don't know whether Sri Lanka, they use mercury manometer, aneroid, oscillometric, digital pressure devices, proper calibrated BP equipment. How many of us calibrate every year? Release of multiple international guidelines with different targets and different recommendations by different societies, creating more confusion. And again, refractory hypertension, complex evaluation of algorithms for secondary hypertension, they were very difficult to follow by practicing physicians. What is a dilemma? A dilemma is a conflict, a problem, or a situation with two possible solutions. What is the Achilles of medical practice? The correct measurement of BP in office. This is very important. The accuracy rate, all of you will be surprised to know, less than 1%. There are 29 patient-related, device-related, and procedure-related biases. So, centuries later, science and the art of BP measurement is still evolving. Like Kaplan says, it's very easy to do, but we do it at the slopiest manner possible. The auscultatory or the oscillometric BP, there are two types of BP, they take auscultatory and oscillometry. And oscillometric, there is semi-automatic, where they get one reading on activation, and fully automatic, they take multiple readings and give the average. But still, many people prefer to use auscultatory. Of course, in a better setup, they also got the automated office BP oscillometry meters. But auscultatory, what's the problem? There is observer skill, weight coat effect, digit preference. We all normally say 120 by 80 or 124 by 84. We don't say 119 by 71. So digit preference is there. Calibration issue. How many of us do calibrate the machines periodically? The manual BP is higher by 12 to 7, 12 systolic and 7 diastolic compared to intra-arterial pressure. So always manual BP is higher than the intra-arterial pressure. And again, the auscultatory versus automated BP, the auscultatory BP shows systolic more than 42. Sometimes it may be less also, but normally it is more than 40, more than the automated BP, and diastolic is around 22. This is a paper from Czechoslovakia, which says the automated BP always gives lesser value compared to auscultatory BP. Again, the home blood pressure monitor, now it is very popular. We are promoting home blood pressure monitor all over the world, especially in India. I am promoting to so many people. Even the home BP, whether you do auscultatory method or the oscillometry in home BP, is more than the office BP. Sorry, home BP is higher than the automated BP, whereas the automated BP is always like equal to intra-arterial pressure. When you compare to the automated BP, the manual BP is much more. So why this question? Why you are worried? Hypertension control rates may appear worse than expected. For example, the automated BP says 120 and the oscillatory BP says 150. Then you feel this control is not there. So sometimes you do over treatment and there will be a lot of problems. There may be hyperkalemia, there may be kidney injury. So this is why we want to know how much the auscultatory BP is much more than the automated. So ideal thing is to have automated BP apparatus in all the clinics. After the sprint trial, people are promoting automated BP monitors. The one reading accuracy was not the criteria. Oscillometric devices become a standard in clinical care because, unlike auscultation, they are able to record blood pressure continuously and you can get any number of readings. The AOBP, automated office BP, produces more accurate and lower reading than conventional manual office BP, which I said, around systolic 15, diastolic 8. But it is not true for semi-automatic or oscillometric methods. So what is my dilemma 2? The dilemma 2 is the current shift is away from manual BP measurement and the recommendation to obtain multiple BP readings at a single visit by automated office BP measure. The problems are, one, the equipment cost. It costs more than 4 times the normal BP monitor. And it takes time. As I said, all of you know sprint trial when the automated AOBP was tried, the nurse will go away and it takes 5 minutes, takes the 3 or 4 readings and gives the average. So time is another thing. Practicality, we cannot do in a heavy OP, outpatient department. Then the automated BP capability to record multiple BP readings after a rest period with a single activation, provide an average of these readings and is not necessary to discard the first reading, can be performed with or without the staff being present, which is referred to as attended or unattended AOBP respectively. See, I have a problem. See, 5 days back, I took a BP of a 57-year-old man with my my automated BP monitor. I mean, this is semi-automatic. The BP was, first time I took 169 by 86, second time 158, the third time 144, and fourth time 148 by 85. Should I consider the lowest or the average or average of the last two? Which one I have to do? Whether I have to consider these two or the average of everything. Normally, whenever you take BP, the last BP always will be lowest. That is why we are in a dilemma. The dilemma 3, the US Preventive Services Task Force 2017 says, before you diagnose anybody as hypertensive, you have to have either ABBM, ambulatory blood pressure monitor, or home BP monitoring for the initial diagnosis of hypertension. Is it practical? In all the 200 million in India, even in Sri Lanka, is it possible to do for everyone who is coming to your clinic to check the pressure in the outside office BP by the ABBM or home BP monitor to diagnose it? The dilemma number 4, based upon the prevalence of white coat hypertension, nocturnal hypertension, mask hypertension, half of the entire population requires ABBM. All of you know what is white coat hypertension. The blood pressure is high in the clinic, whereas normal in the house. Whereas mask hypertension, the blood pressure is normal in the clinic, whereas high in the house. And nocturnal hypertension, people who are having kidney disease or diabetes, they have, especially during night time, the blood pressure is high. They are called as non-dippers. So to diagnose all these things, how do you diagnose all these things? We'll have to use 24 hours APBM. Even if you do 24 hours APBM, somebody will say it's not sufficient. You do 48 BP, 48 hours APBM. And they'll also say one reading is not sufficient because nocturnal hypertension, once you may, one time you may get, one time you not get. So one reading is not sufficient. So is it practical for all of us to do the APBM or HPBM in all patients? The white coat hypertension, the visit 1 is 24%, visit 2 is 12%. That means when the person gets accustomed to the hospital atmosphere, the white coat hypertension may be less. So we don't know whether we have to treat white coat hypertension, whether we'll suppose, if the patient has got white coat hypertension in the hospital, if you don't treat, what will happen? If you treat over treatment, sometimes before the patient goes for surgery, we'll say the patient is hypertensive. We may postpone the essential surgeries also. And then white coat hypertension should be treated. How do we treat? With the echo, LVH, do microalbuminuria, other risk factors, risky family history. There are no guidelines how to treat whether white coat hypertension is benign or we have to treat aggressively. There's a dilemma. Again, I told you the home blood pressure monitor, home blood pressure is always more than the office blood pressure. So when a patient comes to you and the BP is high and the home BP is normal, what do I do? Whether I treat the patient or we get the reading of home BP and then treat accordingly. So what should be your response when HBB is higher than OPB and when OPB is less than the home BP? So there are always a dilemma. So whether you to treat based on the OPB or HBB. See, the meta-analysis of the hypertension prevalence, causes and consequences of mask hypertension, if you see, the home BP is 21% more than the office BP. Same way, if APBM is 17%. So there is ethnic variation also. So this is what we call as mask hypertension. When the patient has got normal blood pressure in the office and then more BP in the home BP, this is mask hypertension. And for everyone, we cannot do ambulatory blood pressure. We will have to do only home BP. And the home BP also says that it can also diagnose white coat hypertension as well, mask hypertension. We did a study in the Indian heart study where the mask hypertension is 18%. In the United States is 16%. In Greece is 15%. In India, the white coat hypertension is 24%, and the United States is 9%. So, can we do for all the patients ambulatory blood pressure monitoring? So, the mask hypertension is also a big problem, like sustained hypertension. We'll have to treat mask hypertension aggressively because the consequence of mask hypertension is same like a sustained hypertension. So, there are no recommendation for drug escalation or management of mask hypertension as of now. The AHA 2019 position paper says there is no recommendation. What do I do? Suppose you are treating the patient with drugs and even then there is uncontrolled mask hypertension at home. What do we do? Should we do escalation of the drugs? We don't know because AHA 2019 also not gives any clear guidelines in the position paper. Then the dilemma number 6 is attended versus unattended measurements. A difference of 10 to 15 millimeters of systolic has been suggested. A familiar medical environment indeed minimizes the difference of attended and unattended. Attend, but do not speak or stay. So that also, affects. So this is another, study where they start auscultatory as well as automated BP monitor, attended and unattended. They found out, they did it to 158 patients. They found out when the patient is accustomed and when the patient attender is not talkative or do anything diversion, both the readings are same. So attended or unattended, whether we do normally, because the sprint trial, it was unattended. The BP, the nurse tried the BP and left the room, and it automatically after 5 minutes took the BP. So there was a dilemma whether to have an attended BP or unattended BP. Again, visit to visit variability. A mean fall of 15 millimeters of mercury systolic and 7 millimeters of diastolic has been described by the 3rd visit, with some subjects even not achieving stable values until the 6th visit. So what do I do? Visit 1, visit 2. Normally visit 3 will be normal, but lesser than the visit 1 or visit 2. But some patients, up to it takes even visit 5 here in this case. So what do I do? Should I change the drug every time when the patient comes? Depending on the office BP? No, I don't know. Whether we do for everybody APBM and correlate with visit to visit BP. I don't know. So static BP as target of therapy versus dynamic behavior in real life. See, whatever you take is only a static BP at that time. We don't know the dynamic behavior in real life. We do not have any HbA1c like, in a sugar. In a diabetic patient, we have HbA1c. Like that, we don't have HbA1c of a BP. And the dilemma 8 is lower the better, regardless of age. The ACC-AHA guideline says the target is less than 130/80 for all. According to the 4th National Family Health Survey in India, 52% of Indians above 18 years have BP of more than 130/80. Should I treat all the patients? Is it possible? I don't know. The dilemma is whether to treat like sprint. In the sprint trial, they say the blood pressure, the target was 123, and they showed beneficial effects. Tight control is good. Whereas if you see in this sprint trial, when you do the tight control, the coronary mortality is less than, is reduced by 33%. In a high-weight trial, if you see, again, when you control with 145, again the ACM is reduced, the CVD risk is reduced to 27%, heart failure is reduced to 72%. So what do I follow? Whether I do intensive control or like high-weight. There is another study from Ontario where their community dwelling residents taking antihypertensive drugs, they found, especially the people with systolic 110 to 119, when you treat them, the benefits are more. There's Ontario study. And even the Bangalore, Missouri, treating elderly with BP lowering below 130/80, they found MACE reduction, CVM reduction, heart failure reduction. So how much do you believe that elevated BP is a physiological response to aging? Completely, partly, or not at all? So how do you adapt ACC guidelines for older patients? You believe in sprint trial, or you believe in the high-weight, or I individualize the treatment? It is always easy to say individualize the treatment. Again, dilemma. So it all depends on the older patient, comorbidities, whether they are frail. In younger patients, we submit them for lifestyle modification, and if they are more than type 1, we'll have to start the treatment. So, but anyway, we should not be aggressive in the older people to reduce the blood pressure. You have to gradually reduce and observe sitting BP, standing BP, and also postprandial BP. Then chronotherapy, another thing. You prescribe drugs, fixed drug combination to be taken in the morning. Some people say in the evening. Or you split the dose 50-50 of morning and night time. This HYGEA trial, which was there, it was very good, which said, you take at least more than one drug at bedtime. Some people said all drugs on awakening. But this HYGEA trial proved, 19,000 people, patients they have done. They said by giving the drugs at the bedtime, the results are good and the cardiac events are reduced. But many people are opposed to it. Many people did not object, did not accept. There were 175 trials. Only 5 trials were given by people, and they found out the CAD and the stroke were reduced when you give the drugs in the night. Again, all morning dose or nocturnal BP is 125 is, all evening dosing again 123, equally divided morning and evening 123. So there are no difference between reduction of the blood pressure. But still people say, the HYGEA trial and the NAPAC study, they said when you give drugs in the night, the benefits are more. I don't know. Again, this is a dilemma. Then isolated nocturnal hypertension. When you do after nocturnal hypertension by APBM, about 10% of the population has it. And that is the culprit. When you have isolated nocturnal hypertension, the chances of they getting CVA or cardiac problem are more. The isolated nocturnal hypertension, 11.5%, left ventricular mass index is more. Isolated daytime hypertension is 7.57%. So how do you treat isolated nocturnal hypertension? Because there is poor reproducibility. You cannot diagnose hypertension, isolated nocturnal hypertension with one reading of ABBM. So you'll have to do second time. You have to do second time and confirm 2 occasions. How do you treat that? Again, there are some dilemmas in treating isolated nocturnal hypertension. Then when you do the BP, always is static. It is not dynamic. So the paroxysmal hypertension, exercise-induced hypertension. What do we do? I had a patient, a 65-year male, radiation to neck for carcinoma larynx, showing BP 220 by 120, and suddenly sometimes 120 by 70 on different occasions. Pseudo-PO. All investigations, whatever you do, renin, CT, MRI, everything normal. How do you treat this patient? You may come across practically, but not every patient is like that. Some, in your practice, sometimes you may get a situation like this. What do you do? Again, treating high pulse pressure. Pulse pressure is a powerful and independent predictor of the incidence of cardiac disease and cardiac failure. Pulsatile hemodynamic stress and marker of arterial stiffness. How to treat a middle-aged diabetic patient who's got the systolic blood pressure of 134 and the diastolic 60? Should you treat 134? Sometimes, you may have a patient with 120 systolic and 50 diastolic. And, in the advanced study, they did 11,040 patients. They found out the pulse pressure is a very important thing. Not systolic blood pressure, not diastolic blood pressure, not mean pressure, the pulse pressure. So how do you treat the pulse pressure? The pulsatile but not steady component of blood pressure predicts cardiovascular events in diabetes. Then which guidelines to follow? Optimal dose of a single drug, optimal dose of 2 drug combination, or the recent ICH guideline says off dose of 2 drugs with diverse mechanism. Start with aldosterone antagonist. You know, there are guidelines which says, recent guidelines, you take, for example, amlodipine 5 milligram, telmisartan 40 milligram. You take it as a off tablet first time. If there's no improvement, you give the combination 1 tablet. Then third time you give 2 tablets. So what do I do? Again, the doubling of the dose of monotherapy, there is only 40% additional BP reduction. Whereas if you give 2 drug combination, it is 100%. For example, telmisartan 40, you make it to 80, only 40% BP reduction. Whereas telmisartan with amlodipine, you get 100% additional benefit. And since you study, if you see the combination at monotherapy, there's only 3.1 difference in systolic, but still the benefits are more because of the diverse actions. And how to start any patient? First A plus C. We were talking about A and B. Now the recent guidelines, ISH international guidelines says you start with A plus C, that is calcium channel blocker, and the ARB or ACE inhibitor as a first line drug. Again, accomplished trial says benzopril with HCT and benzopril with amlodipine. The benzopril with amlodipine combination is better than the benzopril HCT, hydrochlorothiazide. So my point of view, every adult above 50 years benefits from taking blood pressure lowering drugs. There is no one who does not benefit because their blood pressure is so-called normal. So the polypill therapy introduced by Yusuf, then, but HOPE-3 trial says, even though you give polypill and you reduce the blood pressure, sometimes the blood pressure reduction has not got many benefit. And then in this trial, they add statin. So revascularization, heart failure, and all was not reduced with the same type of blood pressure when you do polypill therapy. Again, the CV death, MI stroke, the arrest, cardiac arrest, revascularization, heart failure, all that by candesartan on hydrochlorothiazide is better compared to placebo better. So now, de-escalation, that is another thing. When somebody has got blood pressure control, after some time, do you want to reduce the tablet? And how do you follow? And when do you restart? There are again dilemmas. Then what should be our target? Is it static BP or static numerical BP or dynamic BP variability? Ladies and gentlemen, even in the hypertension 2021, dilemmas are galore. We have to learn a lot because every day, every patient, you learn, and there are a lot of problems in treating the hypertension. So we'll have to solve these dilemmas for better control of blood pressure and achieving reduction in target organ damage, reduce mortality and morbidity. So learning is always the beginning of health. Learning is beginning of wealth. Learning is beginning of spirituality. So thank you very much for the opportunity and for your patient hearing. Any questions, I'll be happy to answer. Thank you.
Thank you, Dr. Murugadathan. And we have a few minutes for questions. Any questions? Yeah. Can I ask? We have a few minutes.
Yeah, that's why, they told me in 20 to 25 minutes I have to conclude, and then we have to give some time for interaction. That is why I rushed for, some of the slides.
So,
yes.
So in the absence of questions, let me to conclude the presentation and thank Dr. Murugadathan for very interesting and informative presentation. Thank you, Dr. Murugadathan.
Okay, fine. Thank you. So you can send your certificate to me by mail.
Okay, sir.
Yeah, because I saw you giving a certificate to the previous speaker. So same thing you can do it. By
we will
email.
arrange. We will arrange.
So I once again thank the chairperson Sudhakar and the president Tilak and my friend Suranga Manikmala. Thank you very much. Okay, thanks for your patient hearing.
Thank you, Dr. Muruganath.
I leave.
A very good evening to you all. We have come to the last session of the day. Here we are from Kandy. I am Sanjeeva Bowatta, the Council of the Sri Lankan College of Internal Medicine. I am joining my colleague, Dr. Keminda Tilakaratne. Let me introduce the speaker for the next session. Professor Sergi A. Jabu. He's a professor of medicine from the Division of Endocrinology, Diabetes and Metabolic Disease from Sidney Kimmel Medical College of Thomas Jefferson University in Philadelphia, Pennsylvania. Let me thank you, sir, for accepting the invitation. And I hand over the podium for Professor Jabu for his speech on SGLT2, Changing the Landscape of Diabetes Treatment. Over to you, Professor.
Thank you very much. I'm very happy to do this. I wish I was there in person, but maybe next year we can make that happen. So I'm going to talk for the next 25, 30 minutes about SGLT2 inhibitors and how that changed the landscape for diabetes treatment. I'll try to finish on time. I have many slides. I could talk on this topic for a whole day, but I try to limit it for 25 minutes if I can. These are my disclosures. So first, I want to start with some background information. We all know how CV disease is common in people who have type 2 diabetes. So patients who have type 2 will be at higher risk of having MI and stroke. The hospital admission rates are much higher in people who have diabetes, and the death rates are high. And the most common cause of death in people with type 2 is, in fact, cardiovascular disease. And sometimes we wonder what's causing that CV disease. There's the obvious part, which is the metabolic syndrome. So patients with type 2 diabetes are overweight in general. They have hypertension, they have high LDL, they could be smokers. But we also have what we call inflammation. And we all know that type 2 diabetes itself is in fact inflammatory disorder. And we know from many studies that patients who have type 2 diabetes have high levels of cytokines like IL-1, IL-6, tumor necrosis factor. So these cytokines can induce inflammation, which can lead to endothelial dysfunction. So that's the not obvious part. And that's one of the reasons when we treat people with type 2, and I'll get to it later, we try to decrease that inflammation, which can lead to endothelial dysfunction. We also know from many landmark studies published over the years, and starting from the DCCT in people with type 1 to UKPDS, ACCORD, ADVANCE, and VATT in people with type 2, that getting A1C to goal will lead to less microvascular complications. So less neuropathy, retinopathy, nephropathy. So that's something we know for sure. When we get A1C down, we get less microvascular complications. But if you look at the initial phase of these studies, there was no reduction in the rates of CV disease or even death. And even in the ACCORD trial, when they try to get the A1C too low, 6% or less, they ended up seeing higher death rates from CV disease. But then all these trials had what we call some kind of extension phase. So when the trial is done, they try to observe patients for a certain period of time. And what they found that if you follow these people for some time, depending on the study, could be 5 years, could be 10 plus years after the trial ends, you still see a reduction in microvascular complications, even when the A1C drifts up over time. But if we follow patients for long period of time, we still see no reduction in CV disease, except in the DCCT, what we call the EDIC trial, so 20 years later, and UKPDS, when they observe patients for up to 20 plus years, they saw some reduction in CV disease and death rate. But remember, the number of patients who stayed in the trial by 20 years was really small. So people challenge sometimes that data we have and say, well, that's not enough because we need a big trial with many patients to show there was reduction in CV events and death rate. But again, the conclusion we get from all this, that getting A1C down to goal will lead to less microvascular complications. But when it comes to CV disease and death, it's not quite sure that glycemic control by itself plays any role in that. And that's kind of, a little bit clear to me, because when we treat people with type 2, it's not just the blood sugars. Remember, there's the hypertension, there's the high LDL, there's the weight issues, there's the inflammation. So targeting just the glucose may not be quite enough to lead to less MI, stroke, and CV death, as opposed to, let's say we look at retinopathy. Retinopathy is mostly affected by glucose, blood pressure to some extent, and some genetics, obviously. So getting glucose down should lead to less eye disease, but it's not the same for MI and stroke and CV death. Now, we know that patients who have type 2 diabetes have multiple defects at the same time. I will not get into it. You've seen that slide many times before. Luckily, we have many treatment options available, which can target one or multiple defects at the same time. So we're lucky we treat diabetics now because of all these multiple options. And the question which always comes up, what is the best option to start with? Obviously, metformin always been the first line option, but then after metformin, what is the best next step? Which agent can get A1C down to goal and provide us CV benefit and renal benefit, and perhaps also heart failure benefit and death benefit at the same time? If you look at all the agents we've had before 2006, when the first DPP-4 inhibitor and the first GLP-1 receptor agonist came out, all the trials looking at SUs, metformin, insulin, TZDs, have not quite shown impact on MACE. When we talk about MACE, we mean it's the non-fatal MI, non-fatal stroke, and CV death. Except few small studies on metformin showed some reduction in MACE. There's one study on pioglitazone where as a secondary endpoint, they showed some reduction in MACE, but not the primary endpoint. So it's not quite conclusive that all these agents we've had before can affect really MACE, until we've had the new classes, DPP-4 inhibitors, GLP-1, and SGLT2 inhibitors. And again, the big change at that time was the FDA, because before that time, the trials were not done per certain standard. And then the FDA required that all trials done on any diabetes drug should show, in fact, safety. And if they show that the drug is superior to placebo when it comes to MACE, that's really awesome, but they need to show safety. So the FDA set a standard on how CV outcome trials should be done on every single drug. The drug can be launched on the market based on the phase 3 meta-analysis data showing safety, but then a CVOT should be ongoing to make sure the drug itself is really safe. So since then, we've had the FDA guidance when it comes to all the new classes of drugs, and that led to kind of explosion of trials. If you look at the slide, it's really stunning how since that FDA guidance, we've had all these cardiovascular outcome trials, and again, that's really great in the diabetes field because we learned so much from all these trials. And I will try to focus my talk more on certain trials. If you look first at the DPP-4 inhibitors, and again, a common one used in the US is sitagliptin. That's the first one on the slide, the TICOS trial. So all the trials done on DPP-4 inhibitors showed a neutral effect. So if you add the DPP-4 inhibitor, you'll get the A1C down. So you might see less retinopathy, neuropathy, nephropathy over time, but you won't affect the severe outcome of your patient. They are all neutral. At least they don't harm, but they don't really help CV-wise. If you look at the GLP-1 receptor agonist, it depends on the trial you look at. It's either positive or neutral. We believe as a class, it's mostly positive because some trials, based on their design and how the statistics were done, we believe that's the reason they were really neutral. So as a class, the GLP-1 receptor agonists are mostly positive when it comes to MACE events. And then if you look at the SGLT2 inhibitors, they are mostly positive when it comes to MACE, heart failure, and also renal. And I will get to it more in details in the next slides. So that's a snapshot of the 4 CVOTs on SGLT2 inhibitors. I'll try not to get into lots of details, but we have EMPA-REG on empagliflozin, CANVAS on canagliflozin. We have DECLARE on dapagliflozin, and the latest one published last year was VERTIS on ertugliflozin. And again, the biggest one out of all these 4 trials is DECLARE, which was 17,000 patients. And the one thing different about it, that 41% of patients in the trial had established heart disease, as opposed to, for example, EMPA-REG, where all patients had established heart disease. So in DECLARE, they had a big number of patients who did not have underlying CV disease, and that's what we call a primary prevention when it comes to our type 2 diabetics. For the baseline demographics, they were quite similar, in fact, across all the trials when it comes to A1C at baseline, to body mass index, to duration of type 2 diabetes. Most patients in these trials had eGFR more than 60. Up to 20 to 25 patients had the eGFR less than 60, and most patients had normal UACR. Only 20 to 30% had a high UACR, mostly microalbumin, with some patients having macroalbumin. And if we look at the primary endpoint, all these trials had MACE as the primary endpoint, except DECLARE, which had MACE or heart failure and CV death. So DECLARE, because it was a big trial of 17,000 patients, they were able to have 2 co-primary endpoints, which were MACE and then CV death or heart failure. Now, when we look at trials, again, we have to look at how these trials were designed and demographics and how many patients in the trial had underlying CV disease. So if you look at this slide, again, lots of numbers, but just to show you that, for example, DECLARE, they had mostly patients without any heart disease. So when you look at these patients, it's going to be more difficult, even for dapagliflozin, to show benefit because you're taking healthy type 2 diabetics, not known to have MI, stroke, or heart failure, and then you're looking at CV events over time as opposed to EMPA-REG, where all patients had established heart disease. So it's easier for a drug you give to show a difference from the placebo arm. Now, if you look at the results really quickly, so EMPA-REG, they showed reduction in MACE events with empagliflozin compared to placebo, was 14% reduction, which was significant. And then they showed decrease in other secondary endpoints like heart failure, for example. Safety, the drug was safe except more genital mycotic infections with empagliflozin, which was expected from all the phase 3 studies done before. For CANVAS, they showed the same 14% reduction in MACE events with canagliflozin. They also showed reduction in other secondary endpoints, including heart failure, which again was a secondary endpoint in EMPA-REG and CANVAS. The drug was safe except for a few things. There was a higher rate of lower limb amputations with canagliflozin versus placebo. It's unclear why that happened. There was a higher rate of upper limb fractures with canagliflozin. We believe it's not a direct effect on the bones. We believe it's through hypovolemia, hypotension. Patients would get orthostatic, they would fall, and they would fracture their upper limb. And otherwise, again, genital mycotic infections, which was expected, again, with this class of drugs. For the DECLARE trial, they had two co-primary endpoints. One was MACE. So MACE was a neutral in DECLARE because, as I said before, most patients in the trial did not have established heart disease, but there was a trend toward less MACE events, 7%, but the p-value was not significant. But the second co-primary endpoint was significant, and that was the combination of heart failure and CV death. So there was 17% reduction in hospitalization for heart failure and CV death in the trial. And if you look at other secondary endpoints, they were all, in fact, in favor of dapagliflozin. Now, if you look at the heart failure component, including the CV death, which was lumped in it as a co-primary endpoint, it did not matter what type of patients you have. So when they did the subgroup analysis, it didn't matter if patients had established heart disease or not, they had underlying heart failure or not, if they had a GFR above 60, less than 60, it didn't really matter. The effect on heart failure was consistent across the board. And that's why dapagliflozin in the US, I'm not sure about labels outside the US, has the indication to prevent hospitalization for heart failure in patients with type 2 diabetes, and that is regardless if they have established heart disease or not. And they looked in the trial at a subset of patients who have HFrEF, which is heart failure with reduced ejection fraction, and they showed in those patients who have HFrEF, there was reduction not only in hospital admissions, but also in CV death. And I will get to it a little bit later because based on that little data from DECLARE on heart failure patients, they came up with a trial focusing on heart failure %. Because in DECLARE of 17,000 patients, only 10% of patients were known to have heart failure at baseline. But it didn't really matter. If you take the 90% without heart failure or the 10% with heart failure and you add dapagliflozin, you see reduction in heart failure admission to the hospital. But I will talk in a bit about pure heart failure patients a little bit later in my talk. And again, that's to show again that it doesn't matter what kind of patients you look at, as long as they have type 2 diabetes, you add dapagliflozin, you see less heart failure events in these patients. One thing interesting they showed, so they said most of the patients we have in the trial don't have established heart disease. But let's look at these patients who had MI in the past 1 to 2 years and see if MACE can change based on that. And that's what they showed. So patients who had the prior MI, now if you look at MACE events, now they were significantly reduced by 16%. Again, same as EMPA-REG and CANVAS, which shows you one thing, that if you take type 2 diabetics with underlying heart disease and you add any SGLT2 inhibitor, you get reduction in MACE events. You take type 2 diabetics with or without heart disease, the only drug which has a primary endpoint of heart failure is dapagliflozin, which showed in those patients, you can see reduction in heart failure admissions. Safety was also same as, EMPA-REG. There was no imbalance in anything except the genital mycotic infections. And again, CANVAS was the only trial where there was imbalance in lower limb amputations and also upper limb fractures, but not with DECLARE and EMPA-REG. And then VERTIS came out last year, and then to our surprise, the trial was neutral. So there was no reduction in MACE events with ertugliflozin. And when it comes to secondary endpoint, there was reduction in heart failure, but again, that was a secondary endpoint in the trial. And same thing, the drug was safe. The only imbalance was the genital mycotic infections. Now, what about renal outcome? If we look at EMPA-REG, CANVAS, and DECLARE, they all had a renal component. And they all showed that if you take patients who don't have kidney disease, they all had normal GFR above 60. Most of them did not have high UACR. If you add EMPA, CANA, or DAPA, you can prevent progression to end-stage kidney disease. But these were not renal trials. The renal component was a secondary endpoint. And in Vertis, same thing, they showed there was some reduction. It was not significant, but there was a trend toward less renal events over time when you compare ertugliflozin to the other arm. Now, if you look at DECLARE, which is stunning to me, the eGFR at baseline was 85, so totally normal. And most patients did not have high UACR. And by adding the dapagliflozin, you see a 24% reduction in renal events over time. Now, speaking of the renal events, Credence was a renal trial, and in Credence, they took patients who have high UACR, more than 300, and a GFR as low as 30, and they showed that if you add canagliflozin, you see a 30% reduction in renal events over time. And that's in addition to ACE or ARB in these type 2 diabetics. DAPA-CKD is a newer trial, and in this trial, which is amazing, a third of these patients did not have diabetes. And what they showed that if you add dapagliflozin to these patients who had eGFR as low as 25 and UACR more than 200, you see a 39% reduction in renal events. And that's in addition to ACE or ARB. And remember, as I said, that 30% of these patients did not have diabetes. So they had hypertensive nephropathy or other reasons to having renal disease. Now, there's also focus on heart failure, as I said before. So in DAPA-HF, they took patients who have HFrEF, so more than 4,000 patients, EF less than 40%. And what's amazing to me, that they included patients who don't have diabetes. So 55% of patients in this trial did not have type 2 diabetes, but they all had HFrEF. And the median follow-up was 18 months, and they looked at the rates of hospitalization and CV death. And what they showed as a primary outcome, there was a 26% reduction in the primary outcome, which was hospital admissions and also CV death. So that's great. So you take any patient with systolic heart failure or HFrEF, doesn't matter if they have diabetes or not, you add dapagliflozin and you see a reduction in worsening heart failure, hospital admissions, and CV deaths at the same time. And that's a great trial. There's safety also in the trial, which was amazing. So when cardiologists look at it, they feel super safe prescribing dapagliflozin. So in these patients on tons of diuretics and different medications and really sick patients, there was no imbalance of anything in the trial, even volume depletion. You would think you add dapagliflozin, you see some volume depletion in these patients. You don't. So there was no imbalance in renal events, in fractures, in volume depletion, hypoglycemic events. So in people who have type 2 diabetes in the trial, yeah, patients could be on SUs, insulin, metformin, and so on. Even adding dapagliflozin in these patients did not lead to hypoglycemia. So that's a great for our cardiologists who might see a non-diabetic with HFrEF. They should be adding dapagliflozin as part of the treatment regimen now to prevent hospital admission for heart failure and CV death. There's another trial called EMPEROR Reduced, and that's on empagliflozin in patients who have HFrEF. And they also had patients who don't have diabetes. And they showed in the trial that the primary outcome, which is similar to the DAPA-HF, there was a 25% reduction. The only difference is that when they looked separately at heart failure admissions and CV death, so in DAPA-HF, there was reduction in both. In this trial with empagliflozin, there was reduction in heart failure admissions, but not CV death itself. It's unclear why. Could be due to the design of the trial. We're not quite sure. So the last slides gonna explore the mechanism by which we see a reduction in heart failure and also cardiac events when we add SGLT2 inhibitors. How does that happen? There are many theories. When you add, for example, dapagliflozin, you see volume reduction, which is great for patients who have heart failure. We know there's less inflammation. That inflammation I discussed initially. We know from many studies that SGLT2 inhibitors lower cytokines, IL-1, IL-6, tumor necrosis factor. So by decreasing inflammation, you can reduce cardiac injury. There's improvement in systolic blood pressure. I will not get to it into too many details, but when you add SGLT2 inhibitors, there's less reliance on free fatty acids used by the heart and more ketone used by the heart, which lead to better cardiac functioning. So all these theories probably play all together to improve a CV outcome in these patients. So if we try to summarize all the data we have, that if you take type 2 diabetics who have underlying heart disease and you add any SGLT2 inhibitor, you would see reduction in MACE events. If you take type 2 diabetics without or with heart disease, doesn't really matter, the only drug in the class which has a primary endpoint of heart failure is dapagliflozin, you would see a reduction in heart failure admissions in these patients. Or you take patients with or without CKD, because these patients can have normal GFR or low GFR, they can have normal UACR or high UACR, you see renal protection in these patients. You add to it the newer trials, so patients who have advanced CKD, now we have two drugs, we have dapagliflozin and we have also canagliflozin and soon empagliflozin to show protection of the kidneys. And we have the trial on HFrEF, which showed dapagliflozin and empagliflozin can also improve outcome in these patients. So that takes me at the end to the guidelines by the ADA. So the guidelines, always say metformin is first line, but the guidelines also say that if you have someone at risk of having heart failure, at risk of having CKD, or someone who has established CV disease, you may want to add a SGLT2 inhibitor regardless of where the A1C is and regardless if patients are on metformin or not. Because from the subgroup analysis across all the trials, we know that even patients who were not on metformin had the same benefit as patients on metformin. So in my opinion, it's not acceptable anymore that we see someone who could be at risk or has heart failure, someone at risk or has CKD, and we don't add a SGLT2 inhibitor because these drugs have been proven in multiple trials I showed you to prevent, in fact, progression to renal events, to prevent heart failure, and also improve CV outcome in these patients. And I will stop here and take your questions. Thank you.
Thank you very much, Professor Jabu. In fact, you are a little earlier, so you have saved some time for questions. The forum now opens for questions. If our colleagues in front of me in the forum, as well as for the people joining in the online platform, can direct questions to our speaker. I do not see any questions coming in on the online platform. Professor Jabu, let me ask a very small basic question. This is about what is your best advice for the patients who are coming with genital infections? Looks like a little limiting factor from the patient's point. What is your best advice?
Right, so first, if you look at all the trials, genital mycotic infections happen mostly in women, and the rates, depending on the study you look at, could be between 4 to 12%. They are rare in men. They happen mostly in uncircumcised males, but the rates in the trials in males were between 3 to 6%. So one thing first, I tell patients in my exam room, when I give any of these drugs in a class, I tell them about the side effect, because if you don't educate patients, and then they get a side effect, they will stop the drug, they may not even call you. So I tell them, and mostly my female patients, that genital mycotic infections might happen. And if they do happen, it's okay. Don't stop the drug, because trials have shown that if you treat that first mycotic infection, it will not come back in 80% of the time while you're taking the drug. So I tell them, do not stop the drug. Go to any store, buy over-the-counter, topical agent, treat it, and then see what happens. If it comes back a second time, then let me know. Then I would prescribe a fluconazole, 150 milligrams, one single pill, and that should cure it completely. Now, there are few women who may get a third, maybe a fourth infection. And here, a few things I do. What we learned from the studies, that if you go beyond 6 months of any SGLT2 inhibitor, the rates of mycotic infections go all the way down to like less than 1%. And the reason is because your body gets adjusted to that glucose excretion, and then mycotic infections just don't happen anymore. So I tell my female patients, just be patient. If you can handle treating these mycotic infections, once we go beyond 6 months, they will stop from happening. And obviously we educate patients on, hygiene and, because that can prevent mycotic infections too. But the key is not to stop the drug when they happen initially, is to treat it and then hope that by 6 months it will not happen again. Now, obviously, in the trials, 0.3 to 0.7% of patients had to stop the drug because of recurrent mycotic infections. But those are patients who've had mycotic infections before the SGLT2 inhibitor. And in those patients, perhaps working on hygiene is key to prevent more mycotic infections.
Yeah, thank you, Professor Jabbour. For your information, of course, I would like to say in this country, of course, in Sri Lanka, this part of the world, we are using both empagliflozin and dapagliflozin. So I think we are also in the correct track in treating diabetes patients. I think I got a question, one question. One question came on the online platform, sir. Do you recommend prescribing SGLT2 for a diabetic patient without diagnosed nephropathy or CVD, even though they have a good control with metformin, sitagliptin alone? If you want to repeat.
So here's what, So here's my opinion. Well, first, if you look at the trials I showed, right? So if you look at EMPA-REG, CANVAS, and DECLARE, those are patients who had normal GFR, they had normal UACR, and adding EMPA, CANA, or DAPA prevented renal progression over time. So these drugs protect your kidneys even when there's no CKD. Now, there's no official indication to use these drugs for kidney protection. We're going to get in the US, in fact, an official indication for dapagliflozin for CKD patients. We have the indication for canagliflozin in CKD patients. But we know from the studies that even in patients without CKD, you get the renal protective effect. When it comes to CV disease, we also know from the trials that you take patients without heart disease, without heart failure, you add, let's say, dapagliflozin, you prevent heart failure in these patients. So in my opinion, if I have someone on metformin and sitagliptin, I would get rid of sitagliptin and replace with the SGLT2 inhibitor. Like in my practice, metformin still first line, that probably will never change. But after metformin, I go for the SGLT2 inhibitor. Because if you compare DPP4 inhibitor to SGLT2 inhibitors, you may get similar, maybe less A1C reduction with the DPP4 inhibitor. But with the SGLT2 inhibitor, you get weight loss, you get improvement in systolic blood pressure, and you get renal protection and CV protection. So in my opinion, why use sitagliptin if you have another drug you can use, which can give you all these CV and renal benefits? Obviously, there's always insurance coverage, which can limit what we prescribe. But in my hands, this patient will be off sitagliptin and replaced with, for example, dapagliflozin.
Thank you very much, Professor Jabbour. I think I pronounced your name correctly, sir.
Yes.
Thank you. In the absence of any more questions, let me thank you profusely. I think, if I'm not mistaken, you joined in very early morning in the day, 6:30 in the morning in Philadelphia.
Yeah, it is. I haven't had my coffee yet, so I will have my coffee soon.
Yeah, thank you so much for taking all the trouble. I would, from Kandy, Sri Lanka,
my pleasure.
I would really thank you and show our entire council's gratitude for this very enlightening presentation. Thank you very much.
You are welcome. My pleasure. My pleasure. Thank you. Thank you.
With the end of the first part of the last session, I hand over the proceedings to my colleague, Dr. Kemindu Tilakaratne, for the next session.
Good evening. Now we are moving to our last presentation on today's academic program. The topic is actually optimal control of asthma. It will be delivered by Professor E.M. Irusan from South Africa. He is the head of the Pulmonology and Critical Care Division, Department of Medicine, Stellenbosch University, Cape Town, South Africa. And he is a past president of the South African Thoracic Society and South African representative on Gold. And let me thank you for accepting our invitation on behalf of the Sri Lanka College of Internal Medicine. So I would like to invite you to do your lecture. You will be given 25 minutes for your presentation. Thank you.
Well, good afternoon, colleagues, and thank you for the invitation. And it's a pleasure to address you on optimal asthma care. It's customary to have a disclaimer. Now, at the outset, I want to emphasize that asthma is a disease of inflammation. In the individual, there's a genetic predisposition, and this inflammation results in these pathological changes, as you see in the airways. Now, the reason I want to emphasize this is, unfortunately, there's still far too much emphasis on this being a bronchospastic disease. And the result of this inflammation results in bronchospasm, airway obstruction, and if not controlled, will end with airway remodeling. And I do want to emphasize that, in fact, every single asthmatic is unique. They need to be comprehensively assessed and a decision plan taken. Now, the reason I mention that is, in fact, when we're trying to control the inflammation, is that there's a continuum of inhaled steroid dose effectiveness. And you can see here that as we increase the dose or use a better quality steroid in terms of its affinity, so we move from preventing death and clinical control to physiological control, then pathological control, and if there is proactive, regular treatment, we can reach a stage of clinical remission. The other reason to emphasize that is, unfortunately, patients tend to default on the treatment, and HCPs don't assess asthma comprehensively, with the result that in repeated audits throughout the world, we find large percentages of patients who are not well controlled and uncontrolled, and which is why I've titled this presentation, Optimal Asthma Control. Now we can use clinical parameters to decide whether we've got control. And so when a patient comes in, we can have a tick box on these items and ask, do they meet many of these simple criteria? Is there control of daytime symptoms? Are they sleeping comfortably and undisturbed? Do they barely need to use rescue? So remember, in terms of rescue, we're talking about salbutamol, none or less than twice a week, not twice a day, less than twice a week. They should be working and exercising without limitation, and they should be at low risk of having an asthmatic attack. And if we do this well and control the inflammation, then we can keep the lung function at about 80% and above. So these criteria, if a patient meets these, then you're doing well. Now, the reason I'm emphasizing pathological control is that there were many studies done almost 2 decades ago to show that when we try to address the airway inflammation, and this was a study where they looked at sputum eosinophils, and they gave enough steroids to control the eosinophils in the bottom line. But in the top one, they used a GINA, and in this case, similarly, the British Thoracic Society guideline. And you can see that when we aim for pathological control, we get much better exacerbation reduction. And if we look at airway hyperresponsiveness, this was also better in those who achieved pathological control. Now, the way to control asthma has been shown best in the Gaining Optimal Asthma Control, the GOLD study, where patients were either given fluticasone propionate or salmeterol compared to fluticasone propionate alone, and therapy was stepped up until we had optimal control of asthma. So you could ask yourself, should one be doing this? And the answer is that when you do that, then you can reach 2 levels of control. On the right is total control. And here, the symptoms I told you about, rescue, nighttime, etc., are completely controlled. Whereas we know it may not be possible to achieve this in everybody. And so even when we do the strategy, we can get well-controlled asthma, where again, there's minimal need for rescue and there's minimal symptoms in a week. Now, when total control was achieved, I need to remind you that there was no need for salbutamol in 7 of 8 weeks. I repeat, in almost 2 months, there was no need to use rescue medication. So when you do achieve pathological control, this is the level of control that's possible. And if you look at the GOLD study over time in different types of severity of asthma, those who are steroid naive, those on low dose, and those on moderate dose, you can see you can get substantially well-controlled asthma over time. And when we look at total control, you can see that there were those in all these strata that could achieve total control. A reminder that the combination of fluticasone and salmeterol always did better than the fluticasone alone. And remember, there was no need for rescue medication in up to 2 months. So if we look at other reflections of this in terms of the quality of life, you can see with the broken graph in the background that most had moderate to some impairment, and with a goal type strategy, the graph moved to the right, where on the asthma quality of life questionnaire, most were scoring 6 to 7, which suggest minimal or no improvement. So when you do this, you can have a substantial impact on the quality of life. And remember, the GINA recommends that we treat so that we control the risk of acute attacks, which can be dangerous and life-threatening. So in the shaded bars in the background was the baseline exacerbation rate. And in the full bars at the bottom, you see the exacerbation rate in the study. So there was some 50 to 80% reduction in the chances of having an exacerbation. And so the GINA organization that advises us on the care of asthma talks about these various steps and the need to step up to get adequate control of our patients. However, in the last year, somewhat surprisingly, they changed the recommendation for mild asthma, where patients were getting salbutamol alone, and recommended that patients should get budesonide and formoterol as needed. Now, if you look very carefully, and the studies were the Sigma 1, Sigma 2, and similarly in the novel start, you can see, if you look at a well-controlled asthma week, for budesonide formoterol, this was 46%, and with regular budesonide, this was 49%. Similarly, for the peak flow and no nocturnal disturbances, all of these were better with regular steroids. If we looked at the asthma quality of life, more improved and fewer deteriorated. In the Sigma 2 study, this was a similar finding. And in the novel START study, all of these were published in the New England Journal of Medicine. The lowest fractional expired nitric oxide, which gives us a reflection of airway inflammation, was best controlled with regular budesonide. Now, it's not that I'm saying this. In the two pivotal Sigma papers, Professors Paul O'Byrne and Eric Bateman were senior members on the science committee of GINA. Both stated unequivocally in the New England Journal of Medicine that regular budesonide and a short-acting beta agonist was superior. Similarly, in the novel START, Dr. Beasley said that regular budesonide is superior to the PRN strategy. Now, why should that be? Well, if one understands how budesonide works, one can understand the results. Now, if we give a high dose of inhaled steroid, the inflammation comes under control and the airways spontaneously dilate. So here was a patient given 1,600 micrograms of budesonide. We're monitoring the peak flow and time. And you can see that as the airway inflammation comes under control, the airways open up. But after about 8 hours, the inflammation returns as the budesonide is washed out of the system. And when the inflammation comes back, the airways begin to constrict. So budesonide only works for 8 hours. So if patients are taking it intermittently, there may be substantial periods when the patient has got no steroids in their airways and there's ongoing airway inflammation that's causing bronchospasm, a decreased quality of life, and the chances of airway remodeling and fixed asthma over time. Now, this is nothing new. We've known for a long time that regular inhaled steroids provide superior control. This was another paper in the New England Journal of Medicine. And on the middle, you see as-needed budesonide. And on the right, we've got daily inhaled corticosteroids. So for peak flow, it appeared adequate. But when it came to bronchial reactivity, sputum eosinophils, exhaled nitric oxide, and asthma control scores, these did not change with the as-needed budesonide, but all of them improved to a greater and statistically significant level with the regular inhaled steroids. Really, there's no other graph that shows this so clearly, that daily steroids are the way to go. And many asthma experts, including myself, wonder why this drift to as-needed treatment. It is clearly inferior. This is also so with the single maintenance and reliever, the MART type strategy. Here's a paper by Dr. Rabe, and we see the baseline situation. And when we look at symptom-free days and rescue, et cetera, and follow that over time, we see that on the MART treatment, patients were symptomatic 60% of the time. And patients were still needing a reliever every day. Both of these do not meet the GINA definition of well-controlled asthma. So patients were better, but they were not optimally controlled. And in fact, what we see in the regular versus single maintenance MART type strategy is, in fact, when patients take an extra dose of the medication, they're actually taking more budesonide. So those in the MART were taking 50% more budesonide than the other group. So what we're seeing is actually the effect of more inhaled steroid. And as I said at the outset, this is the best way to get asthma under control. But clearly, here, the patients needed even more budesonide. Now, a fundamental problem with MART and sigma is that they are reactive. So there's airway inflammation, bronchospasm, and the patient is reacting. Whereas regular maintenance treatment to achieve that clinical remission I told you about is proactive, preventing the inflammation. And perhaps that's best shown in this graph, that in a sigma or MART type strategy, there's inflammation, which causes the symptoms, the patient reacts, and after that they stop or decrease treatment, and the inflammation returns. So these two maintain the cycle of inflammation. Whereas the regular inhaled steroid, in this case, there's inflammation, you treat, the inflammation comes down, symptoms are decreased, and there's less inflammation, and you break the cycle. So this stops the cycle of inflammation. So in the first situation, we have the increased inflammation, whereas in the second, we have caused the inflammation to subside or regress. Now, people may say, well, there's airway inflammation, but when we look at patients, how do we know what's happening inside the airways? We can't measure exhaled nitric oxide easily, and we don't have other tests. And the answer is that the short-acting beta agonist, salbutamol, gives you a sense of whether you're controlling the inflammation or not. Here we have frequent short-acting beta agonists. And that's because there's no inhaled steroid, and we have a high level of inflammation. And as we increase the dose of inhaled steroid and the inflammation comes under control, so there's less need for the salbutamol to the time when you have optimal control and there's barely any need for salbutamol. So the salbutamol use tells you how much of inflammation there is. So a goal type strategy is working on the right where we're getting optimal control. A smart type strategy is intermediate. And the worst is the GINA PRN strategy, where patients are taking medicine almost all the time. Now, one of the other problems is when we pass on control of asthma to patients. but patients may be poor perceivers of their symptoms and may not take treatment when they ought to be taking it. Another reason touted by Gina is that they say that beta agonist overuse is linked to adverse events. They say that regular or frequent use of SABA results in beta receptor downregulation, decreased bronchoprotection, rebound hyperresponsiveness, and a decreased response, and there's more inflammation. Now, this in fact is not true. The SABA is not causing the inflammation. The inflammation is causing the increased need of a short-acting beta agonist. So again, this is a surrogate for inflammation. And it tells us that we're not managing the patient properly. They are either defaulting on their steroids or we haven't given an adequate dose. So, in conclusion, regular use of inhaled steroids controls the underlying inflammation and should be the cornerstone of treatment, and has been shown in studies spanning 20 years that regular inhaled steroid provides superior asthma control versus intermittent treatment with as-needed SABA or an as-needed ICS long-acting beta agonist. Step up to regular inhaled steroids and a long-acting beta agonist is the best way to manage asthma, and ideally in a single combination inhaler. So when the patient uses the inhaler for the relief from bronchospasm, they get the inhaled steroid passively, and they can't omit that dose. And finally, like with all chronic diseases, we need to optimize the partnership between doctors and patients so they understand the disease and will comply with what you tell them to do. So many of you know this analogy that asthma is like an iceberg. We tend to treat what we can see. So if we're working on the top on just symptoms and exacerbation, then we're working at a very superficial level, and we do not get optimal control. Whereas when we give adequate steroids in a proactive, regular dosing fashion, as exemplified in the GOAL strategy, then you start controlling the airway inflammation, bronchial reactivity, and airway remodeling. You have the full picture, and you are closer to getting complete asthma control that's best for the patient. Thank you very much.
Thank you very much, Professor Irusan, for that wonderful lecture. We have a few minutes, couple of minutes for the questions, either from the audience or from online partner attendees. I have one question from you, sir. This is regarding, now we have been using long-acting theophylline in our country, theophylline, which now, of course, latest guideline, they have removed that one from the guidelines according to GINA 2020. I just want to know what is the reason for that, as well as what is the place of biologics in the management of asthma, especially uncontrolled asthma. And as you mentioned, inhaled corticosteroids. Now that is the cornerstone of treatment. And what about the side effects, regarding when it comes to higher doses of inhaled corticosteroids? So just want a few answers. Thank you.
Thank you for that. Okay, so the first one was on theophylline. So the combination inhalers with the long-acting beta agonist and inhaled steroids give you superior levels of control with lower side effects than theophylline. So that's the reason it's been removed. Theophylline is a weak bronchodilator and a weak anti-inflammatory and has a host of side effects. So if we can use superior treatment that's safer, then that's better. The second question was on the biologics. The biologics are a little bit expensive, and are reserved for severe, difficult asthma. So the vast majority of patients can be controlled with inhalers alone. That's about 90% of patients. In terms of the side effects, the inhaled steroids are in microgram doses, and small doses are given only to the site of inflammation. They are remarkably safe. And apart from local side effects, there's almost negligible systemic side effects. So there have been Cochrane reviews on this to show that there's little effect on the hypothalamic pituitary adrenal axis, for example, in terms of cortisol suppression and weakness in the bone, osteoporosis. So the Cochrane reviews have shown these to be exceedingly safe. It's only when we go to oral steroids that we start having these, and in the difficult asthmatic, where we've got to use multiple agents.
Thank you very
much. So for the vast majority, they're quite safe. Go ahead, sir.
Thank you very much. Once again, I would like to thank on behalf of the Sri Lanka College of Internal Medicine for your excellent presentation. Thank you very much, sir.
Thank you. It's a pleasure to address you. Thank you.
With that, I think we have come to the conclusion of today's program. We wish you all a pleasant evening. Thank you.